this morning. Welcome to the Royal College Foundation Trainee Conference 2023. My name's Tade. I am a consultant psychiatrist working in general adult psychiatry, but having done lots of other things before. And I am the Royal College Specialist Advisor on Foundation Training. I will be chairing the conference today and introducing the speakers and telling you a little bit about the speakers before they come and join us. Really excited about the programme today. We've got some fantastic individuals coming to talk to us of different grades as well. So foundation trainees, core trainees, as well as professors and leaders in their fields. Now, as I said, it's a really interesting programme. We've tried to include a little bit about different careers, specialities within psychiatry. So for those of you who might not have had much experience of psychiatry, either as students or as foundation doctors, you get to hear about different specialities. But I've also tried to bear in mind the context within which all of this is happening. Many of you are working extremely hard under really difficult conditions. There's been junior strikes all year, and I think it would be really hard to keep motivated, keep going, and sort of keep your head above water and think about what you're going to do next month, let alone next year or the next 5 years. So the speakers have all been chosen because, not just because they're leaders in their own fields and inspirational individuals, but also because they have managed to maintain their enthusiasm, motivation, resilience, even though I'm not really sort of kind of massive fan of the word resilience. They've managed to maintain their love for what they do. And I wanted them to be able to share some of that with all of you, for you to start thinking about how you build that into your careers and think about having a sustainable career in mental health. So I hope you enjoy it. Before we get started, a couple of housekeeping things. If you can put comments and sort of general things into the chat, but any questions you've got for our speakers or for me or for the team, please put into the Q&A. If there are any questions in the Q&A that you particularly like them, you can like them, and they'll go to the they'll be prioritised to be asked, rather than sort of repetitively asking the same question. Our backroom team, Patricia, Claire and Georgia, thank you so much for helping out. There, and we'll pick up any sort of process issues or any things you've got about sort of application foundation jobs, but I'll also ask our speakers to pick up any questions particularly for them. There will be time for questions in between sessions, so please, if there's anything particularly you want to ask, please do keep the questions coming, and I'll try and respond to them as well and pick out any particularly interesting questions. So without further ado, I'm going to hand you over to Alice. Alice is a previous winner of the Foundation Royal College Psychiatry Award. She's caring, compassionate, and always puts patients first. In her first ever post as a doctor, her performance was comparable to a competent core trainee in psychiatry. She not only has a robust theoretical knowledge base, but also understands the nuances of psychiatric diagnosis and the impact of social isolation in marginalised communities. Thank you so much, Alice, for coming to talk to us, and I'm going to hand it over to you now.
Thank you very much. I'm just going to share my screen. Can you all see that?
We can.
Lovely. Right, I'm just going to put it on full screen. So hi everyone, my name is Alice. I'm one of the core trainees based at the Northern Deanery. And I just want to say a great big thank you to the Royal College of Psychiatry for inviting me along today to talk about my foundation trainee experience, specifically my psychiatry experience in this programme. So to give a bit of background about me, I graduated from Newcastle University in 2021. I then completed the academic foundation programme at the Northern Deanery, which I just finished earlier this year. And I guess my first kind of interest in psychiatry first started in my 4th year of medical school. Unfortunately, I was the year where COVID hit quite hard, and all of my medical elective and placements of that exciting 4th year got cancelled. So what I did to kind of fill out my time was look online for research opportunities and other opportunities to build my portfolio. And I happened to stumble across an opportunity to get involved with a systematic review alongside a group of consultant psychiatrists based at the Northwest Deanery. And together we did a systematic review looking at patient satisfaction with telepsychiatry, which at the point was the pinnacle of delivery service because of COVID measures. And this led to oral and poster presentations at some national conferences and gave me a really good academic research skill set that led to my place on the AFP. And even now it's really useful to work on my projects. I then went on to work in the foundation program. And my actual first job of F1 was in forensic psychiatry at the CNTW Trust, which, as its name on the side, is a wide-spanning trust covering a number of regions. And what this involved was attending a particular forensic supported accommodation in the community, delivering daily visits to the residents for a specific subset of patients who were under a section known as Section 42. And this means that they tended to be stepped down from either hospital or prison under Section 3741, and they just stepped down into rehabilitation for the community with some community restriction orders in place. And what this residence did was it provided assessment, treatment, and rehabilitation services for these patients who were all aged over 18 plus, who either were a danger to themselves or to others in the community with an element of mental health disorders or a learning difficulty that we could support them with. And I got to work with a number of multiple health professionals with a wide range of experience. And this included psychiatrists, psychologists, hostel and service managers, support workers, community psychiatric nurses, occupational therapists, and social workers. And we all worked really well together in a team to facilitate eventual discharge for these patients. And we saw a range of conditions, including schizophrenia, schizoaffective disorder, anxiety, bipolar, psychosis, depression, as well as other forms of mental health disorders as well. So what did it involve in my day-to-day job, aside from kind of routine visits? So I got to attend some outpatient clinics that were nearby the supported accommodation, which was more of a housing building. And the practices, the clinical ones, I got to be involved with routine blood checks. So patients who are on antipsychotics like clozapine would need regular full blood count checks, help out with ECG checks. I got really good at reading ECGs and perform physical health monitoring, including blood glucose checks and checking their BMI. And that's because of the mental health conditions, as well as their medications that increase their risk of morbidities and mortality. On a day-to-day basis in the actual housing accommodation, I performed routine physical health checks. So patients might have a resolving chest infection that they got antibiotics from the GP for. They might have a bout of gastroenteritis. So it's performing a routine physical health check. And I was always supported by a health worker or my consultant psychiatrist who would attend with me. So I was never always alone. I also performed lifestyle interventions and delivered public health advice. So patients with a high BMI, we'd counsel them on obesity and support them to lose weight, talked about alcohol and smoking cessation and managed their comorbidities such as diabetes. And we performed regular medication reviews. A lot of these patients were on routine medications, including painkillers like codeine. And we'd again review their need and any ongoing side effects for this. And interestingly, my job involved attending patient tribunals, which were held by the Ministry of Justice, which was a unique experience where I got to listen in on why the patient was there and how we're working towards getting them discharged. My job also involved attending some inpatient visits. So although I was based in a community, the base site, St. Nicholas Hospital, was based in a bigger hospital. And here I got to work with some core trainees at the time and specialty trainees to review more of the acute unwell forensic patients that were in the inpatient wards. And similarly, we'd perform routine general physical health exams, as well as deliver mental state examinations and come up with formulation plans in helping these patients. And as well as this, I got to be involved in regional teaching and listen to really interesting case discussions and new research that was upcoming in the field. Again, a unique aspect or element of my job in forensic psychiatry was that I got to attend some prison visits. And this would be once a week on a Tuesday. And I got to attend Tade prisons, which involved a very thorough security screening, both before even being allowed to go into the building, as well as at each and every visit. And again, we performed similar kind of mental state examinations, physical health reviews, progress reviews, and worked really closely with the health psychologists to make sure that we were achieving the progress that we needed on a weekly basis. And similarly, we saw a range of patient presentations from schizophrenia, schizoaffective disorder, patients with psychopathy, and antisocial personality disorders. So as you can imagine, psychiatry is a bit more of a slower pace compared to my colleagues working in the acute wards. And so I had a bit more time to work on my portfolio a bit more, learn a bit more about audits, as well as quality improvement projects, which is one of the learning outcomes for foundation program. And you need to pass the year essentially for the ARCP. So I got involved in a couple of audits during my community placement, looking at DVLA diagnosis, for example, informing them about new mental health disorders, an audit of compliance with obesity guidelines, similarly to the obesity advice that we'd give to our patients, as well as the physical health monitoring and seeing whether we're compliant with making sure they're getting their checks on time. And similarly, I got involved in a really interesting quality improvement project. And what happened was I started on forensic psychiatry, not knowing anything about sections other than the ones we get taught at med school, such as section 2, 3, 5.2. But it was the first time hearing things like section 3741, section 42. And actually, I realized a lot of the patients themselves didn't quite understand what their section was. And this was based on our consultations and their attending tribunals. And the majority of my patients were on this step down section 42, so that they can live freely in a community and supported accommodation, but with community restriction orders. And what I did was I created a questionnaire to assess their general understanding in areas that they'd like to understand a bit more. And I assimilated information looking at existing trust resources, mind leaflets, Ministry of Justice documents, as well as consultant knowledge. And I transcribed all of this into layperson language, wrote up a leaflet, and this is now a trust-wide resource for our patients who are firstly introduced into section 42. We also got the leaflet reviewed by staff members from a range of MDT to get their opinion on it, and it was very well received by both patients and staff. And when we did a post-leaflet survey, patient knowledge actually improved significantly. And one of the extra comments on the evaluation survey was that they wished for resources like this to come up sooner. And I guess all of this led into further presentations. So every project I do, I tend to get something out of it. So I wrote up some abstracts and submitted it to some national conferences. So I got to present some of my work at the Faculty of Forensic Psychiatry conference, as well as 3 of my posters at the International Congress in 2022. I also got to present a case study at the Regional Forensic Psychiatry Journal Club, and it got me thinking about the kind of impact of early life into these patients' lifestyles now and the decisions that they've made. And finally, I got involved with a lot of teaching. Again, we had a bit more of a slower pace in psychiatry, so I got to get stuck in with this. And I had loads of final year medical students that would rotate onto the campus site. So I'd get involved in simulation teaching, where we'd get role players coming in or actors coming in to role play, and we'd perform cases on alcohol dependence, depression, anxiety, schizophrenia, and so on. And this was really useful teaching because it got to develop my communication skills, how to facilitate the students on a wider basis. I also got to act as a formal tutor for final year medical students. They would rotate on a 3-weekly basis, and I'd meet weekly with a group of 5 or 6 students to provide pastoral support, debrief on the cases that they'd see, and highlight learning points that we can take forward for their final year examinations. And funnily enough, I got to be involved with OSCE examination in medical school as well. So I've got to help these medical students essentially pass their exams from the start all the way to the finish. And that's something that I'm really grateful for. So I guess that's everything I've touched upon of my foundation experience. And this is what I've got up to in my psychiatry post. And I still see psychiatry on a day-to-day basis in every aspect of my job. So it was a really useful and invaluable work experience for me of having that placement, and I would 100% do it again. And I just want to say a great big thank you to Dr. Niti Sud, my educational clinical supervisor for the entire year, who provided amazing support and nominated for me for this award. And thank you so much for the Royal College of Psychiatry again.
Thanks so much, Alice. That's kind of very impressive run through of everything that you've done within a very short period of time. There's no questions in the Q&A, but we've got a couple of minutes. So I guess I wanted to ask you, what tips would you have for other foundation trainees? Obviously, you're kind of working as a core trainee now, but how, if other people are struggling to find those opportunities, or maybe not do as much as you've accomplished, but maybe, what tips would you have for people who are foundation trainees now who want to find out more, but maybe aren't getting as many opportunities to do so?
I guess a lot of it is just being a bit more proactive and not being afraid of people saying no. I think a lot of people, and consultants especially, would be grateful to have you on board to do any research projects. It's just reaching out. So having a look on maybe the Trust intranet page or the website, looking online on ResearchGate and finding which consultants are actively involved, what their specialty of interest, a particular subspecialty is, and seeing what projects they want some assistance on. And anything you submit, such as even audits, make sure you submit an abstract at the Royal College of Psychiatry conferences, for example. It's a good way to get communication skills, presentation skills, as well as another thing ticked off on your ARCP for the year. So I definitely recommend trying to reach out.
Thanks, Alice. And what I'd say on sort of in addition to that, there's several Royal College conferences as well as local conferences. So obviously there's the sort of big international conference, which is always looking for submissions from junior trainees and medical students. But in addition to that, there'll be sort of specialty conferences. So if you're interested in forensic, for example, if you work in forensic, they do their own conference, or child and adolescent. There's the medical education and training conference, which is specifically for trainees and trainers. Which will accept submissions particularly related to training. And then there's also the local faculty conferences. So, for example, Alice was based in kind of the Northeast, so there'll be a Northeast local conference. So there's lots of different opportunities out there as well, isn't there, Alice, to submit those things?
Yeah, definitely. And also journal clubs as well. Get involved with them. It's a good presentation opportunity and really interesting case discussions.
Thanks so much, Alice. Really, really enjoyed listening to that. And I can see we've got Goodwin on. Welcome, Goodwin. It's lovely to see you again. Dr. Tong was one of our previous Foundation Psychiatry Fellows, but is now working as a core trainee in psychiatry. Now, obviously, most of you will be foundation trainees and will have an idea of what it's like to work as a core trainee, but there are differences between training as a foundation trainee in psychiatry and what you experience, and then actually working as a specialty trainee. And we wanted Goodwin to talk a little bit about those differences between being a foundation trainee and a core trainee, and what he thinks the advantages of that might be. So thank you so much for coming to talk to us. Really, really grateful to you. And like I said to Alice, what I'm going to do is I will pop on the screen sort of a minute or two before you're due to end, just so you know that kind of time's coming up. Is that all right?
Lovely. Thank you.
Lovely. Thanks ever so much.
Thank you very much for having me, Dr. Das. Thank you, Alice, for that lovely talk earlier. So I just wanted to talk a little bit about my experience and being a core trainee. I'm currently a CT2 working in older adults in the community setting based in Worcestershire and Herefordshire. As I said earlier, I was a foundation trainee a couple of years ago. Had a really good time, which is why I decided to just choose psychiatry. I had the best time in psychiatry amongst all my other placements, so it didn't really take too much convincing to decide to what I want to choose for my future direction. I started. I think I'll just start off by explaining how core training works in general. So in first year, we normally do 2 6-month placements. The first one is usually general adults, either in the inpatient setting or in the community setting. So if you do inpatient in the first 6 months, you probably do outpatient community setting in the next 6 months, or vice versa. And in the second year, you normally do same again, 2 6-month placements, either in older adults, learning disability, children and adolescents camps, and these can either be in the community setting or the inpatient setting as well. And then in your CT3 year, you can choose other subspecialties that you might be interested in. For example, forensic psychiatry, perinatal psychiatry, liaison work. Some trusts offer early intervention, or if you're interested in PICU, high intensity psychiatric care, that's usually an option as well. I think the main difference that I found being a core trainee as compared to the being a foundation trainee was the increase in responsibilities that were given to me, which initially I found a little bit challenging. I was quite used to being a foundation doctor, having senior support. I still get senior support, but there is a gradual increase in responsibility because now you've got junior trainees under you. They sometimes they look up to you for direction, for advice, and I found that initially a little bit challenging because usually I just turn around and look at my registrar like, okay, what do you want me to do? I remember the first couple of weeks, people were doing that to me. I was like, oh, what should we do? Okay, so that got a little bit getting used to, but after a couple of weeks, I sort of got used to it, relished the opportunity to practice some leadership skills. And making some small decisions by myself. So I really enjoyed that. So I was just thinking, over the past week, what I should talk to you about. So I thought, I've reflected about my past year as a core trainee, and I thought about some interesting ways that I've been able to practice medicine differently as a core trainee in psychiatry rather than a trainee in some other speciality. So I think I'll just share with you some of my reflections. I think firstly, there is a lot of holistic approach in practicing medicine. So diagnoses can always be the same. Schizophrenia, you see lots of patients with schizophrenia or bipolar personality disorders, but every patient is unique. And to me, that's very interesting. I get to learn about their stories. I get to practice a holistic approach, which is not always possible in, say, an acute setting. In acute medicine, because there's always time constraints. A ward round is rapid in surgery or in medicine. You don't really have time to interact with patients. You don't explore their social history. You don't explore their family background, things like that. So I get to treat more than just the symptoms. I get to see the interplay between the biology, the psychology, and the social factors of the patient. And we get to play a role in helping these patients with these problems that are often deeply intertwined with their whole life experience. I get to provide a more comprehensive care that I don't think I get to do in acute medicine. The second thing I thought about was my resilience and empathy. Quite a lot of people think psychiatry is it's a bit more relaxed, but I think it's a little bit different. I think it's demanding in different ways, and I think working in psychiatry definitely demands resilience and empathy. Some patients might be relatively more straightforward in diagnosing and treating, but I think some patients are ever so much more difficult. And I feel every difficult patient that I meet, it tests my resilience and empathy in different ways. So by seeing these patients, although sometimes it can be emotionally challenging, by going through this process with them, it allows me to forge deep connections with my patients, and through my interactions with them, it gives me this opportunity to practice, building my resilience and empathy towards these patients. And I'm not sure if you've got the time or the energy to do that in another specialty. The third point I want to say was about being involved in breaking down the stigma in mental health. So that's something I care about. I think the stigma surrounding mental health is always has been there for a long time, and it's still there, although lesser than before, but it's definitely still there. So in our line of work, we get to advocate for change, and the way we do this is educating our patients in every face-to-face setting, every interaction with the patients and with the families. We get to change these stereotypes, albeit a little bit slowly, one patient at a time. But it makes me feel good that I'm contributing to the breakdown of these barriers that previously might have prevented people from seeking help. So I often like to tell patients or the families that that mental health is you can see it as important as physical health, and there's no shame in seeking treatment. Furthermore, I think mental health is the awareness of mental health has grown exponentially in the past 5-10 years, and I think the spotlight on mental health is likely going to get bigger. It's relatively young specialty, and with plenty of new research coming out weekly. You can see in the BJ Psych lots of new interesting research, plenty of research opportunities if you're academically inclined. That's it might feel good to be part of this revolution. The next reflection I thought was about the long-term relationships I've forged with some of my patients. It's definitely a highlight for me. I know for myself, one of the things that drives me is patient satisfaction. And unlike other medical specialties, patient encounters are often brief, and you might not see them again. But in psychiatry, just like general practice, we get to form slightly longer term relationships with some of our patients. And even as a trainee, I get to see patients repeatedly, sometimes on the ward. They come in a couple of times, a few times across my period with them. And then the next thing I know, I go into the community, and then I see them again in clinic. And sometimes, even after I've left the post, I see them whilst being on call. So some of these patients, you eventually develop a rapport with them, and you get to use this rapport to produce change. And I find it quite fulfilling. I can't forget this one encounter that I had with one of my patients that I didn't see him first. I saw him on the ward first. He was diagnosed with bipolar affective disorder, and then when I went into the community, I saw him again. And at this point in time, he was on a verge of manic episode relapse, and we were looking at the time of possible readmission. And fortunately, he remembered me from the time on the ward, and he was presenting quite agitatedly, very confused about everything going around him. I could tell his pressured speech and his crowding of thought he was just all over the place. He was very upset, and I was there with a couple of nurses, and we were talking about trying to encourage him to take his medication, and otherwise we're starting to head into the direction of readmission, and he was really upset about it. Eventually, after some talking to him, and he looked at me and he said, "Oh, Doc, I trust you. I'll take these new medications that you're suggesting." And at that point in time, I didn't know how to describe that feeling, but I went home feeling very privileged to help this man, possibly to prevent a readmission and help him feel better. So it was a very, very satisfying feeling to be able to help this person. The last thing I think I would like to talk about is the work-life balance. I think being a core trainee in psychiatry gives me this good work-life balance compared to other medical specialties. It is not as physically taxing. I don't do 4-night stretches anymore, so that's nicer for my well-being and mental health. I think I was quite burnt out by the end of my foundation training, and going to psychiatry, I didn't fix my burnout immediately, but over time, over my first year, I've had, supervisors and registrars, consultants who actually showed some compassion towards me. I felt that they genuinely cared about my workload. They often ask me if I have got time to do notes, or do I have time to reflect about my week? Am I going home on time? And I felt appreciated for the work that I've put into onto the ward, onto the clinics. Yeah, I'm not saying it's easy. It's definitely demanding in other ways, emotionally. But I think in summary, I felt a lot of personal fulfillment in my job so far, and I would definitely recommend it to anybody who has an interest in psychiatry. So yeah, I think that's all I have to say for now.
Thank you so much, Goodwin. I was really kind of moved actually by some of your reflections about how, the thing that you find builds resilience is your relationships with patients. And that's what 25 years later, that's what I still come back to, relationships with my patients as well. So it's kind of, I was really moved to hear that, and also to hear that you felt supported as a core trainee by your trainers, and it doesn't, as you say, it doesn't fix burnout, but you feel more valued. And I'm really pleased to hear that. So thank you so much. There's a couple of questions in the chat, in the Q&A for you.
Cool.
Would you mind answering those? Because I'm aware Dr. Boland's joined us, and we haven't got very long with him. So I'd like to move on if I can, but thank you so much. So Dr. Boland, this is a very brief bio for somebody who's done a lot. He's the current quality improvement lead for the Faculty of General Adult Psychiatry, but also the previous chair for the Faculty of General Adult Psychiatry at the Royal College of Psychiatrists, works at South West London and St George's, where he is the Executive Medical Director. He's very active on Twitter and a great champion for general adult psychiatry as a speciality, which I think sometimes tends to get forgotten. We're delighted that he's been able to spare some time to come and talk to us. So without any further ado, I'm going to hand it over to him. Thank you so much.
Well, no, thank you. And how long have we got for the session and then questions? I think it's 10 or 15 minutes, isn't it?
You've got 15 minutes, but if you need to go, that's fine. We can answer some questions on your behalf. So yeah,
delighted to stay. Yeah,
fantastic.
Wonderful. Well, great to be here, and thanks so much for inviting me. I was really touched to be asked to talk about general adult psychiatry, actually, because I've been doing it since 2001, an awfully long time. I'm still really passionate about it to this day. My main day job these days actually is that I'm a medical leader and manager, really. So the majority of my week, 4 days of my week, I'm working with the Trust's executive team and the Trust's board, essentially overseeing the quality and the safety of services that we provide in South West London and St George's, which is a mental health trust in South London. We've got over 3,000 employees that work for us, hundreds of psychiatrists, but even more nurses, psychologists, peer support workers, estate staff, pharmacy staff. Yeah, it's a big organisation. And we provide a massive range of services for children, older people, general psychiatry services like I provide, and some national services as well. We've got one of the country's few OCD inpatient units and deaf services. So actually trying to make sure all of those provide excellent care, that all of the doctors are properly supported and trained, that our services are safe, all of our wards are safe and things. It's a big job, so it does take up a lot of my time. But I still do clinical practice. So every Monday, I work in an assessment team. And yeah, essentially, I get referrals from GPs, start with a blank sheet of paper, or blank electronic record, I should say, really. And yeah, try to work out what somebody's presenting with and how to help them. And I still really thoroughly enjoy that. For me, doing clinical practice helps me in my job as an executive director, because I'm the only person on our trust board that sees patients or does any clinical practice. So I know how our trust services are working firsthand, if you like. But also, it's something that I've enjoyed ever since I was a medical student, actually, and was reaffirmed when I was doing what was it? Well, in my days, I was called a house officer, but it was basically the equivalent of your foundation program. And I'd been one of those medical students that had enjoyed pretty much everything that I'd done, right? So I did pediatrics and thought I'd be a pediatrician. Then I did general practice and thought I'd be a GP. So when I was doing my foundation program, I had a pretty open mind actually about what I was going to do for my future career. But it was over that first year that the penny dropped for me that psychiatry was going to be my future. And essentially, it was because I realized that I was just naturally drawn to understanding understanding an individual, understanding the patient's psychiatric history and background, wanting to know more and wanting to figure out how to help someone. So, I mean, you all know what it's like getting called down to A&E in the middle of the night to see somebody with chest pain, or somebody with urinary retention and things. And whilst that was interesting and I felt I was making a difference, in a way, I found myself asking the same questions, over and over again, going through the same kind of process. But if I was seeing somebody that had come in and after an overdose, for example, and we'd worked out how to manage and treat that overdose, I then found myself asking the questions about, well, why had that person taken the overdose? What had brought them there? And also started thinking, well, what will stop them doing it again? How do we help people to move away from that in the future? And that really kind of sparked my fascination, because everybody's story is completely different. And so how you support somebody after an overdose, how you treat mental illness, whilst we've got a big range of evidence-based treatments, both medications, psychological interventions, and more. Actually, how you tailor those to any individual person requires skill, time. You've got to be able to listen. You've got to keep up to date with your clinical practice. You've got to keep your physical health skills up to date, because you've got to exclude all sorts of organic causes for somebody having a mental illness. So I've never regretted it. And so when I trained as a psychiatrist, you have to kind of train as a general psychiatrist in the first few years anyway. In order to pass your MRC psych, you've got to do a bit of this, bit of that. I did some CAMS, children and young people's mental health services, did some learning disability stuff, addiction. I did some research, and I moved into general psychiatry training because I'd enjoyed most of it. I remember thinking I would perhaps like to do intellectual disability, but I settled on general psychiatry, thinking that, well, there'll be I'm sure I'll see some patients with neurodevelopmental disorders in general psychiatry and be able to see other presentations as well. And that was absolutely the case. So general psychiatry for me means that I'm exposed to absolutely everything in the Oxford textbook of psychiatry, right? I get to see absolutely every different type of presentation. I normally work with people from the ages of 18 to 65. That's what general adult psychiatry does. But yes, 18-year-olds can be, adults, but they can also be practically children. And we increasingly work with older people as well in general psychiatry. We sometimes work with people with a history of learning disabilities. If people are encouraged to access mainstream services, we work with people with neurodevelopmental disorders and the rest. So for me, I really value the variety. I did the other thing about general psychiatry is that a lot of the specialties of psychiatry that you might be hearing about today are in fact subspecialties of general psychiatry. So I was the chair of the general adult faculty at the Royal College of Psychiatrists. I just stopped doing that role in July of this year. But a number of our other faculties, such as the rehab faculty, the neuropsychiatry faculty, perinatal, these are effectively subspecialties of general psychiatry. So you can't get a certificate for completion of training in those subspecialties. You have to do general psychiatry training and get what's called an endorsement to your CCT to be able to specialize in that. So actually, neuropsychiatrists, perinatal psychiatrists, liaison psychiatrists, and many others are general psychiatrists as well, really, and have a general psychiatry CCT. So if you're interested in lots of different things, it's a great specialty to go in because you can explore you can explore what your interests are over the course of your career. I seriously thought about subspecializing in a branch of general psychiatry. Really, really enjoyed it, but again, when I got to the end of my training, I realized that I wanted to have the variety and flexibility of that general psychiatry offers, and so that's what I chose. And remember that general psychiatry, it doesn't mean that you will by default always practice with a wide range of presentations. So specialist early intervention in psychosis services. So if you're particularly interested in working with young people that have their first onset of psychosis and working in a specialist team, your route to that is training in general psychiatry. So like I say, careers are long. I was 31 when I became consultant for the first time, and it felt like ages to get there and do the training and pass the exams and get all your sign-offs and everything. But when you turn 31 and you look ahead to, I don't know, 65, 67 when you might retire, that's a long time. So you want to stay interested and engaged over that time. So no, I've mainly specialized in community psychiatry over those years, and but I've done other things, inpatient psychiatry and others, and I still really love it. So I look ahead to the next 20 years, excited and looking forward to new challenges, and who knows what I'll be practicing in the next 5 years' time. So I guess that's all I wanted to say. But yeah, happy to take any questions.
Thank you so much, Dr. Boland. Like you, I'm a bit of a magpie. I've trained in general adult and forensic, but I've worked in eating disorders, home treatment, personality disorders, and acute and inpatient. It kind of gives you variety and I think people who have a low boredom threshold, I'd thoroughly recommend it. Thank you so much. We're going to do questions sort of at the end of the speciality pitches. Now, I know you'll probably be really, really busy and might not be able to stay till the end. There will be some questions in the Q&A box. So I didn't know whether you wanted to answer those, stay around, come back to the questions. Speciality questions are going to be at about 5 to 12. So it's very much up to you. We'd love you to stay, but if you can't, I totally understand as well.
Oh, thank you so much. I actually came at this time because I've got a board meeting today, sadly, that starts at 11 o'clock, which is just around the corner for me. So I'm going to have to dash, but it's great to be here. Thanks so much for inviting me.
Thank you so much for coming. We really appreciate it. Thank you, Dr. Boland. And now we've got somebody I'm really excited to hear from. Professor Henrietta Bowden-Jones, OBE, is a psychiatrist and neuroscience researcher working at CNWL NHS Trust. Many of you will have heard of her, not just through psychiatry, through kind of media, Twitter. She works as an expert advisor to both Westminster and House of Lords on matters pertaining to gambling disorder, gaming disorder, mental health. Many of her articles are in sort of newspapers as well as scientific journals and kind of psychiatric journals. So kind of, yeah, I'm sure you'll be really excited to hear this next speciality pitch as well. Professor Bowden-Jones will be delivering the presentation slightly differently in an interview format, and we'll be joined by her trainee, Filippo, who'll be asking the questions. So I will stop talking. Welcome, Professor Bowden-Jones. I'm so pleased you could come today. Thank you ever so much, and I'm going to stop talking now.
Thank you so much. I'm so happy to be here. I will have to leave as well after my talk, but do please put any questions in the chat and Filippo will pick them up and we'll stick to time. And thank you so much for inviting me, and well done to you for having so many trainees here. And if anyone doesn't get a question in, you can always email me at any time later. I'm very keen to encourage lots of you to go into addictions. Filippo, thank you for doing this. And this is an example of what you can do as a senior psychiatrist. You bring your trainees into anything you do. And actually, Filippo is not so much a junior trainee now, as he's very far ahead in his training. But great. Hi.
Hi, Professor. Let's start with the first question. So could you tell us a little bit more about your life and career, and why did you choose to become a psychiatrist?
The main reason I ended up in addiction psychiatry, really, when I look back, is always dating back to my early years. I was born in Italy, grew up in Milan, Italian-speaking family, even though my father was English. And there was a heroin epidemic in Italy at the time. And I often talk about having to walk to my primary school at the age of 6 and 7, stepping over bodies of people who were injecting heroin. And I would ask people, and I would say to my mother, say to my father, what are those people doing? As I could see them injecting, I could see them heating things up, using a lemon, going for the vein, taking off the elastic band from the arm, all of that. And they would say, oh no, well, those are addicts. No one, don't talk to them, just walk over and, just look away and walk to school. And I always felt that probably those were the early seeds of what happened later in my career to end up with me. In fact, my first ever job at CNWL, and many years ago, was the consultant for the injecting drug users at St. Mary's Hospital. They weren't deemed to be deserving of a room in the hospital, from what I can gather. They were given a caravan to keep them away from everyone else. Those were, I'm talking 30 years ago. They had literally, it was a prefab caravan at the back of St. Mary's. And that's really, when you talk about parity of esteem and the need to have that in mental health in relation to physical illnesses, and then in mental illness and addictions in particular, it's a real issue. And the caravan was an indication. But then later, when I worked at the Soho Rapid Access Clinic, being the consultant for the homeless people with addictions in Soho Square and central London, again, I think there was a connection with my early life and feeling so helpless when I wanted to help those poor people in the streets then.
Yeah. And I know that after your training in psychiatry, you achieved a doctorate in neuroscience, and you studied the role of ventromedial prefrontal cortex in alcohol use disorder. So how important is for a trainee and for your career in general to have a research background?
I'm so happy you've asked me this question. I truly believe that pretty much everything that happened in relation to setting up the first national clinic for gambling disorders 15 years ago, the first the National Centre for Gaming Disorders in 2019, really happened because I was deemed to be an expert. And the reason you become an expert is, I don't need to go through why you become an expert, but the reason it was helpful was that when it comes to niche experiences and delivering treatment, I think people didn't really know whether it was going to work or not, whether actually my idea of setting up the first ever NHS clinic for gamblers was a good idea. I was told initially I should do it in my spare time, in my special interest afternoon. Well, within about 18 months, I had 900 referrals a year. So clearly that wouldn't have worked very well. But it really was the fact I had done my medical doctorate at Imperial, and those 6 years of studying had given me some sort of certainty, at least personally, that I understood there were people who were at risk, who needed help, who were now exhibiting these incredible harms from an activity that was being commercialized without enough protection. So there was the issue of treating them, but also the issue of campaigning for them as a group and making sure that things could change at national level. And I really, looking back, feel, and I always say this when Imperial College put me forward for interviews, etc., they did a video about, well, how do you think in Imperial College helped your career? And I'm like, well, I think it made it, because I don't think I would ever have been trusted enough. So there is an issue here about research. Often I have people coming up to me saying, oh, I'm no good with research. Well, that means nothing. It is something that belongs to an era that we no longer inhabit. Everything you do needs to be evidence-based. But if you have the evidence, and then that way other people can learn from it. And I think there is an issue about giving people self-confidence around the ability to get started. So sure, book chapters for other people before you write your own book is a good idea. And that's certainly how I started many years ago when I was on the young and on the exec committee as a sort of junior doctor representative at the Faculty of Addictions. But equally, already, if there's an interesting case study that you think might be good, please, find more senior people who've got experience and get their advice and get started. I often talk about the fact that I almost didn't have a research career because a well-meaning consultant offered me a research project, and I was young, I was pregnant with my first child, and he said to me, here's a box of suicide notes. These are the people who jumped into a London Underground train and died. And these are the messages and the suicide notes from the people who didn't die. And could you just analyze them and tell and sort of write up about the differences between the two papers? And of course, I was pregnant and very, very upset and emotional by reading all these dead people's notes and thought, oh, I'm no good at research. And just to give you an idea about someone who is, obviously able to do stuff, can be influenced just by the wrong setting, the wrong environment, as that was. And he was very well-meaning. He just didn't think it through, really. But there will always be good evidence-based projects for all of you. And once you get started, it becomes like a second language, and you'll always be more of an expert for having done that.
And did you have any mentors that influence your career? Or in general, how important is to have a guide, a mentor in a medical career?
I truly believe mentors are fundamental to giving people opportunities. People often say, well, how do I find my mentor? I'm told to just, find people who know you and who work with you. Well, if you're lucky, that will be the case. It certainly was for me. We were at the Chelsea and Westminster Hospital as junior doctors, as senior house officers, and Dr. William Shanahan was there. He was the addictions person there. And he had a very senior role within CNWL. Eventually, he became our addictions director, and he always put us forward. I still remember a cold sweat as he said to me, I need to lecture at Charing Cross. There are going to be about 200 or 300 people there. Last minute, I can't make it. You need to do it. And I just thought, oh my goodness. And then I realized, that was it really. Either I was going to step up or I wasn't. But if I wasn't, someone else, someone else was going to do it, because of course it was a beautiful opportunity and I needed to do it. And so I remember being there feeling very uncomfortable and thinking, this is the way to fight any fears about public speaking. And after a few opportunities, I enjoyed it greatly and still do. But I'll never forget that moment where he said, don't, nonsense, just get on and do it. You'll be absolutely fine. And he always gave us opportunities, all of us who then went on to train in addictions. And so right now, what I always try and do is take people with me wherever I go, really, if I can, and introduce them to new environments, and always share publications with people. And as I said, today, having you here is exactly that opportunity. Sometimes you don't have the fortune to have people who are willing or able to take you under their wing in your environment. And my suggestion is look out for them in areas that you are keen to inhabit professionally in the future, and make time to go and meet them. Ask for a meeting or go to a lecture they're giving. I have a very good example when someone kept on emailing me at the time when I was very, very busy with the gambling clinic expansion. And I had to sort of slightly bat him away, not because I didn't want to help, but I just didn't have capacity. And eventually a third email arrived saying, dear Dr. Bowden-Jones, you have said no to me twice, but I really need to explain to you, I really, really need to meet you because my career lies in your field and I really need you to take, blah, blah, blah. So I was like, oh my goodness, I have done this young man a real disservice by not helping him. And I wrote back and I apologized. I met him, and sure enough, he went on to do a master's and a doctorate in Cambridge with all the group I work with, and is now one of the leading stars in my field. But if I look back and I think, gosh, I'm so glad that he insisted, because someone else might have not. And so please take that also as a lesson. Don't give up. Sometimes people are only very busy, not that they don't care and don't want to help.
Really inspiring. You mentioned your work with gambling, no? And now for many years, but actually you have a role. So you are the National Clinic Advisor for the government on gambling harms. So could you tell us which are the next challenges in tackling gambling in the country?
Yes, the role as a National Clinical Advisor for NHS England was a really enormous privilege, because it was the first appointment of this kind that this country has ever had. And it was an indication to me that everything we had done for 15 years in terms of bringing evidence of harm to the government had worked enough for them to understand that we did need a national clinical advisor. We have them on everything else. We've got a suicide one. We've got them on other things. So that was great. Now the national. So what happened in our field is that finally, after years of collecting evidence, the white paper came out in April, stating that there will be a levy for independently funding all the work that needs to be done in gambling disorders. And that includes treatment, which will be very much NHS driven, research, which is now not really happening enough because there are no proper funds to do the research, and indeed prevention and education. So the next phase now is that the government is in the middle of a consultation period that's about to end. And then it will all be about implementing into a final version what was the white paper from April. So I suppose my role has, is still very clinical. I'm sitting here in clinic now. I stepped out of my team meeting in order to come and talk to you. But it very much is, my mind at the moment is very, very much on the politics, because I feel strongly that this is an opportunity not to let things slip and to ensure that everything we feel needs to be included can be. And so I use clinical data all the time. I provide evidence of harm and experiences of, for example, leaving gambling for a moment. There's a big article in The Guardian from a few weeks ago about the gaming clinic, and there will be a science podcast that they're going to be issuing, a Guardian Science Weekly podcast on the gaming clinic coming up next week. It's all about bringing the evidence to the general public, saying, look, we don't know how many gamers with problems there are because there's no national prevalence survey. So the first thing I'm asking is we should fund an independent prevalence survey to understand how many people are experiencing harm, what the harm looks like, where it's located geographically and demographically. And then let's focus on the treatment and what is needed. I think we need clinics all over the country, not just my little clinic in London, even though it's a national clinic. So I think what I'm hoping to do today is to show you how important clinical work is, not just at patient level, but actually at population level. The more you understand an illness, the more you can bring data, the more you can start to think about prevention. And that, to me, ultimately is how you're going to end up doing the best, the most significant amount of good with your knowledge.
And so you mentioned the gaming clinic, which is the first and the only one for now clinic in the UK dedicated to the treatment of gaming disorder. Is the patient suffering from gaming disorder different from the gambler? And if yes, could you tell us why?
Thank you, Filippo. They are very young, very young. They are being referred by their parents. They're dropped out of school very often, or sometimes dropped out of university. There's a lot of violence. A lot of violence is being exhibited within the family, within the home. I've had children who've had to be put in foster care, children who have harmed themselves or their parents or their pets or their siblings in a kind of aggressive outburst when people are trying to take their devices away. We're learning every day. You know, we are not, even though we're probably the most expert you can be in this country in relation to this illness, in the great scheme of things, we know so little. For example, I don't know whether they're all mostly going to be young men, or whether it's a young men living at home who are being referred, but there might be, you know, older women gaming like crazy all over the country, suffering harm, and we don't know about them because all we can say is that this is what's coming through the NHS clinics' doors. What I will say is that the level of distress is enormous, and we are treating families as much as we're treating the individual in order to change the dynamics and reduce attentions. And this is working. We're getting good feedback, and we are, again, here's another example. When you run a national clinic, you are really trailblazing. So we've developed the first treatment program for gamblers. We are now doing it for gamers. The gambling book is available now. It's called Breaking Free, and it's published with the Royal College of Psychiatrists and Cambridge University Press. And now we're working on a gaming book. So I see you, Artie's appeared. So probably I need to stop speaking now.
I would rather you didn't stop speaking. I have to say, it's been so interesting, but I'm aware that you'll need to get back to your team meeting as well. Obviously, I know you won't be able to join us for questions afterwards, and we'll try and answer the questions as best we can and maybe redirect a few to you if that would be okay. And also Filippo, if he's able to join us. Before you go, though, chair's privilege, there is a question I wanted to ask you, which is about how, you know, for trainees in training, the numbers of substance misuse posts, because as Dr. Boland said earlier, you train in general adult psychiatry and then you get an endorsement in substance misuse. But the availability of substance misuse endorsements has rapidly diminished. How do you feel about that as somebody who, you know, is passionate about this speciality?
Thank you for asking. I am devastated by having witnessed the last 15 years of reduction in funding for these posts. And I almost feel bad about telling you, but I think it is important for people to know how it was in order to try and get us back there. There was a core group of national students who were junior doctors who were all training, and there was a group called the National Clinicians. I can't remember what it was called exactly. It was called SCAN, and they gave funding for people to have experiences. You know, I ended up winning a fellowship. I ended up in Canada exploring the homeless drug users of Vancouver. This was, a really important formative experience. We were able to rotate jobs and do all sorts of inpatient training and the inpatient work in addictions is extremely severe. I cannot, I'll give a talk about it some other time, but if you don't have that training, it's very hard to feel that you can deal with anything coming through. And all the perinatal addiction stuff is so important within the context of inpatient addictions. So what I'm hoping to see is a decision by government to start to invest again properly in not just the inpatient units, but in the training, in order for all the people who left, because of course then I witnessed all my wonderful friends and colleagues needing to go back to general mental health, because of course London was there were more jobs in London than there were in a lot of other parts of England, and sadly people had to continue with their employment, but I would very, very much hope that we can return to those years and use the expertise that is, because all of us are getting old, we're getting close to retirement, but we were the young, then it all changed. So I'm hoping we can pass on as much as we can to future generations, and the college knows that all of us would be keen to support any move towards expansion of posts. Yeah.
Thank you so much. And I'm aware we're a little bit into the break. I just wanted to say I'm so grateful. We're so grateful for you taking time out of your extremely busy day, busy schedule to come and talk to us. You're always so inspiring when I hear you. And I'm sure the trainees will have been inspired by just those sort of last 15, 20 minutes. So thank you.
Thank you. Artie, one last thing. Twitter is very important. That I always tweet opportunities and free places for conferences.
Brilliant.
Age Bowden Jones OB, you can find me. And literally, I take people to lots of meetings. If so, do follow if you're interested in addictions. Bye.
Thank you so much. Thank you. So we're going into the break now. After the break, we're going to continue with the speciality pitches. I know there's been a question about maintaining well-being, resilience, but I'd like to bring other people into that into the answer to that as well. So I'm not ignoring that. I will answer that a little bit later. So it's now 8 minutes past 11. If we can all come back at 11:15 to start promptly for Dr. Douglas, that would be great. Thank you so much, and see you in a few minutes.
Yeah, okay.
Okay, welcome back, everyone. I hope you've all had a chance to get a cup of tea or a drink, refreshments, have a little bit of a walk around, maybe had to think about what you've heard this morning. So we've got another two really great speakers before we then go on to the speciality sort of questions section. The first is Dr. Chris Douglas, who's a consultant psychiatrist and also a medical psychotherapist. Now, I know there was a couple of questions in the chat earlier about dual training. So Chris may touch on that, about the process of dual training, how you enter dual training, but also how that works, how you sort of wear two hats, and what that looks like in your consultant career. Chris is also really interested in foundation training. He's a foundation TPD in Yorkshire, and I'm particularly delighted to introduce Chris, because he and I trained together as trainees in the last century. That's quite how old we are. So we're both still going, we're both still smiling. Welcome, Chris, and thank you so much for coming to talk to us today.
No problem. Okay, so you might need to bear with me slightly. I'm just going to try and share my screen. Hopefully it will pop up. Let me just try and get it on my screen. I did get it shared earlier, but okay. Right, let's see. Can you see medical psychotherapy up on your screen?
No, you're currently sharing an email from the conference.
Okay.
Calendar invite, I think.
Yeah, it's yeah, it just disappeared from the sharing options. So okay, let me just try not to panic here. I'm very used to working with Teams, so why is it not here? Okay, I don't quite know why it's not.
Do you want to quickly send us a copy We can share it for you.
Yes. Okay, so we'll send that to
Patricia or
okay.
careers.
Yep, okay. So bear with me 2 seconds, apologies. It's using, am I sharing anything I shouldn't be at the minute, or?
No, you stop your screen sharing, you're fine.
Okay. Sorry, who, Patricia, isn't it? Yeah.
Patricia,
okay.
yeah.
Okay, so hopefully, yeah, just sending that. Okay. So anyway, so just to introduce myself first of all, as Artie said, I am a medical psychotherapist, and I have been working in medical psychotherapy for over half of my career, but I've also worked in psychiatry as a consultant psychiatrist, and as Artie says, I have been more recently focusing on foundation year trainees as part of my career, and having been a college tutor focusing on core training before that. So I've got quite a wide experience of helping trainees, and at some point hopefully you should get my slides come through to come up on the screen. Apologies, as I say, our trust won't even let us download Zoom. We have to use the web portal. So
it's fine. You won't be the first and you won't be the last in the history of Zoom.
No,
We've been doing it for 3 years and we still get to this sometimes.
Right. Okay, so
what we'll do is we'll pop them up as soon as we've got them.
That's fine, yeah, and we whiz through them. So yeah, the first slide will be a picture of Manchester Medical School. I think once that's come through, get up on the screen. So dealing with technical gremlins, obviously something that par for the course with these online conferences.
Just to confirm, have you sent them through?
To Patricia, yes.
Yeah.
But let me just, that's gone through. It's in my sent box to Patricia.
Okay, perfect. Yeah.
Okay. Let's see if it pops up again.
Right, give me 1 sec.
Okay.
I've got them.
You've got them. Great stuff. Okay.
Yeah.
Apologies, everyone. I'm just not familiar with this. So do you want to pop them up and we can whiz through them relatively swiftly?
Yeah, if my computer wants to open. Okay, give me 1 sec.
Do you know what? I'm just going to try a different strategy. 2 seconds. Let's see if this works. Okay, so can you see them now?
I can. Do you want to share them or do you want me to share them?
I've got control of them now. So okay. So this is University of Manchester. That's where I studied medicine in the 1990s, and that's where I first started my journey. I actually had some interest in psychological therapy prior to going to medical school. So I was already had an interest in psychology and did some work experience in a psychiatric hospital in Shropshire, which was very interesting and very smoke-filled from my memory. And this is Sheffield, Northern General Hospital, where I went on to do my postgrad training in psychiatry as what would have been the equivalent of a core trainee and higher trainee. And whilst I was in Sheffield, I did a general adult CCT. So I did higher training in general adult psychiatry with a view to doing a dual training. But as a quirk of my training, I actually did 2 separate higher trainings. So for those who are interested in doing dual training in something like general adult psychiatry or CAMS or forensic psychiatry alongside medical psychotherapy, there are options, and they are quite well designed 5-year plans. Mine was do your general adult, then do your medical psychotherapy. But it was 20 years ago or something like that, so quite some time ago. So, okay. This is the first psychotherapy centre I started working in as a trainee in a place called Ossett in Yorkshire, which is not far from Wakefield, and used to have a pleasant drive up there to see my patients when I first was training. And this is where I work now in Huddersfield as a medical psychotherapist, and where I'm talking to you from right now. So I do like where I work. It's a lovely area and plenty of nature and countryside around in the surrounding fields. So it's impossible to find a picture of therapy without the therapist holding a notepad, no matter how hard you look. And I'm not a good artist, so I didn't fancy doing that for myself. But so one of the things about therapy that you will have seen on TV programs, movies, etc., is it's a talking treatment. You know, it's about trying to help people by simply the power of listening to them on a regular basis and talking with them on a regular basis. So, and I think one of the things that we don't necessarily think about, which is a real advantage of medical psychotherapy, is that you get more time than anyone else. Psychiatrists already get more time than a lot of our colleagues in other specialties in medicine to spend with their patients, to get to the bottom of things, hear about the family history, etc. But in medical psychotherapy, you get even more time. And one of the strange things is that as a medical psychotherapist, you actually will pick up some things that are not picked up anywhere else in medicine. If somebody has a very subtle side effect of, for example, an antidepressant, you have an hour a week, which might be going on for 2 years when you're seeing that patient, and every time you're seeing them, and you can see, you know, that they've got a slight movement disorder as an side effect to their antidepressant, and also you can see it disappear when they stop taking their antidepressant. I've picked up someone with Klinefelter syndrome that had been missed all their life. They were in their 70s, you know, because I had a lot of time to sit and talk to them and listen to them and observe them. And I've also picked up things like a patient who mysteriously had terrible diabetic control, who was supposedly an absolute saint at adhering to his diabetic regime, but 18 months into a 2-year therapy, he revealed to me that he goes and has jam and cream scones at 2 o'clock in the morning when everyone else is asleep. So nobody knew what he was up to. So this iceberg, you know, it's a picture to bring to mind about the unconscious. So if in medicine, psychiatry, much of the time we're looking at the bit above the water. You know, we're looking at what we can see, what people can think, what people can remember, how people can answer our question. But in psychotherapy, you are often more interested in the things that are hidden, the things that people don't realize that are in their mind, the things that are influencing the way they behave, the way they have relationships with others, etc. So that's one of the things that is most interesting to me, is there's this hidden part of the mind which kind of gets overlooked in other areas, and you get time to really explore this in therapy with patients. So these are two of the stalwarts of my training: Sigmund Freud, who I'm sure you will have all heard of, and Melanie Klein, who I'd be surprised if you've heard of. But Sigmund Freud was very much the father of psychoanalysis, and in a way, Melanie Klein kind of became the mother of it, you know, and looked at some of the things that Sigmund Freud hadn't looked at later on, when she took on his work and developed it further. So it's a picture of Sherlock from the TV series, because I think one of the things that really appeals to me is that you get to be a puzzle solver in medical psychotherapy. You know, you get to watch people's behavior very closely. Sherlock Holmes would sort of watch people tapping their fingers and, you know, deduce that there's something going on that doesn't quite match what the person is saying or presenting, that there's something going on behind the scenes. And it's very satisfying when you do decode, you know, something that's helpful for the patient to help them understand themselves, and that finally makes sense of these patterns, unhelpful patterns of behaving and relationships they've had all their life. One of the things you cover in medical psychotherapy is you don't just think about the patient in front of me. You think about what were they like in their development. You know, what was their early years like? You know, and maybe it's an older patient you're seeing who's had all these different life experiences, and they all contribute to the person that you're seeing in front of you. You think about attachment theory. It's Harlow's monkey who's decided he'd rather have a cuddle from a comfy mother robot rather than the other mother behind, which is supplying milk. So, you know, as human beings, we like contact. You know, we like to be connected to people. It's not just about being fed, or and that's Lawrence in the middle, who's got his geese who formed an attachment to him when they came out of their eggs. So we can think about people's psychological defenses. You know, we all put up defenses to help us to deal with life stresses, uncertainties, anxieties. And we can take a look at, because some of them will be helpful, some of them will be unhelpful, some of them pass their sell-by date. You know, so, you know, this is one of the things you tend to think about and explore in medical psychotherapy. Contradiction is something that is very much inherent in human beings. We say one thing and we do another, or we want to be with our partner and we don't want to be with them at the same time. And it's quite hard to hold that contradiction in mind if you don't have a model that accepts that our minds work in more complicated ways. And some of these things are, you know, buried in our unconscious. One of the things that you may well do if you do medical psychotherapy training is you may do some self-exploration. You know, you may get your own therapy. It's certainly commonly part of medical psychotherapy training is that you get to be a patient yourself and to see what it's like being on the receiving end of therapy, which I think really helps both to get a sense of yourself, but also to be able to empathize with what it's like for patients when they come to see you later on after you've, you know, as part of your training and later career. So I'm not expecting anyone to particularly recognize any of these people, but what I'd like to think about is, what on earth do all these people have in common? Is there anything that you can tell that all these people seem to share? Appreciate you might not be able to answer. I don't know if someone's brave enough to put their microphone on. So I'll tell you who they are. So the top left is a lady called Hannah Segal, who came up with some interesting papers looking at how patients make us feel, how they stir up things in us, and that's useful information that we can use to make sense of what's going on inside our patients. The person below her, Donald Winnicott, who looked at how people how mothers connect with their infants, and how mothers might have some quite mixed feelings about being mothers, for example. Wilfred Bion is the bald man with glasses on. He was a tank commander in World War II, and he developed some quite technical theories about how our thoughts work, but he was also a very important figure in developing group therapy. And we've got Edna O'Shaughnessy and Irma Brennan-Pick. So I've actually met Hannah Segal, Edna O'Shaughnessy, and Irma Brennan-Pick, and the common factor for all of these people is they're old. And what I remember as a trainee was I looked around at my colleagues who were in psychiatry at that time. People were able to retire at 55. And many of them were looking forward to retiring at 55. And then I would go to a conference where someone was talking about psychotherapy, and I would see these ancient people, and they would be lively, they would be engaged, they would be interested, engaging with the influence, presenting papers. So I thought, well, that looks interesting. These people are still interested right at the ends of their life. You know, maybe that's something I'd like to do, because it obviously is interesting enough for them to carry on doing into their 80s. So I think that's a good advert for medical psychotherapy. Here's a joke that you may or not get, but I thought it's quite funny. This person is seeing a picture of their parents fighting, and plainly it doesn't look anything like that to me on this picture, on this person's mask. But what it is it's a Rorschach test, which looks at what's going on in our own minds. You know, what do we see on these random shapes? And my final slide, just before I run out of time, is just a amusing gift I got bought, you know, because people knew what I was interested in. So hopefully that's okay, and I will hand you over to my colleague.
I was just making a note of the after therapy mints as a great present for certain people, Chris. Thank you. Thank you so much. There's loads in there that I want to kind of, I'd love to kind of unpick and ask you more about, Chris. Are you staying for questions at the end? Because there's a few questions for you in the Q&A.
Stay for the next lot of questions.
Yes, yeah. So just before lunch then, brilliant. There's a couple of questions for you in the Q&A. You can choose whether you want to answer them sort of type or maybe answer them live as well. But it's certainly stirred up a lot of interest. I'm now going to introduce Dr. Lily Reid, who is a specialty doctor in old age psychiatry at Northamptonshire Healthcare NHS Trust. She's the SAS tutor and the CSER Fellowship Scheme Lead. So CSER is how people get a certificate or equivalent certificate of training if they haven't gone through sort of the standard core training, high training route, and also a medical appraiser. She also chairs the Royal College Staff Grade Committee. I'm so pleased Lily could come and talk to us, not just about old age psychiatry, but also for you as foundation trainees. I didn't want today to be just about consultants and professors, as fantastic as they all are. There are different routes to working in mental health, different stages to working in mental health, not just training, but alternatives to being a consultant and alternatives to, you know, you don't have to just be kind of consultant professor, those kind of things. As laudable as that is, you can have a really, really fulfilling, valued career in other kind of in other routes that you take. And I think Lily is a really great example of that. So thank you, Lily, for coming to talk to us today. I'm delighted you could come and talk to us, and I'm going to stop talking and let you get on with it.
Thank you. It's really, I'm really pleased to be here today. Thank you for inviting me. Georgia, my slides are with you, and to prevent the delay, do you mind sharing them? I would be really grateful. So I am a SAS psychiatrist. I will tell you a bit about my career. I trained abroad. I came to the UK on a scholarship. I'm an academic type person. I did a second degree in psychology. I then had a master's degree in old age psychiatry from Manchester University. Then I did a PhD at Leeds University in psychiatry. Throughout this, I worked in various psychiatry posts in general adult psychiatry and old age psychiatry. They will be now called trust grade posts, but I had a combined academic career, quite a senior academic career, in which I managed to secure millions of pounds of funding and run my own research group. I then was asked by the UK government to head up their medical research program at the government, and I moved to do so, and I became Deputy Chief Medical Advisor at the Department for Transport, where I worked for 7 years. During this time, I had a contract and worked as a psychiatrist for 2 days a week at the Maudsley Hospital, which is one of the best known hospitals in the UK, which is based in London. I then decided that I would like to do psychiatry full time, and I became a specialty doctor. And this is a route for people who haven't gone through training, or they have been IMGs and come with quite a bit of experience, or for people who want to pause and think whether training, a return to training is for them, or whether they want to do other things, including progressing to becoming a consultant via something called the CSER route. So this is my career. I have now worked in old age psychiatry for 15 years, and I will tell you why I think old age psychiatry is the best specialty. Can we go to the next slide, please? So I think it's the best because as foundation doctors, you have a good general medical knowledge, and you have all had some posts in that environment. Of all the subspecialties in psychiatry, old age psychiatry involves a lot of medicine interface and a lot of common knowledge. So lots of us read ECGs, order and interpret blood results, liaise with cardiologists, liaise with neurologists, with all sorts of other professionals. We also skilled in chronic long-term condition because our patients generally, but not entirely, start at the age of 65. So all of them, in terms of physical comorbidities, they will have significant and very different comorbidities than younger people you see in general adult psychiatry, but also because for the mental health part, they may have had mental health disorders for decades, and many of the available treatments would have been tried before. The guidelines of what's effective and the evidence has changed since they tried it. And there's a very good challenge and looking at this person with physical comorbidities and with a long history of trying various things for their mental illness, and with them together trying to make things better, not necessarily just in the medical domain, because we are also looking quite differently than other subspecialties at the environment of this person, the social context, the experiences they've had in their lives, and how the sort of determinants of health, the socioeconomic determinants of health in everybody play out by the time they've been at play for decades and people got older. Now, our unique expertise amongst all psychiatrists, so we can do everything else, everybody else does, but our unique expertise is in cognitive disorders. And I put in brackets and delirium because many of you who are in acute hospital, you will know that delirium presents with psychiatric symptoms and is quite often a difficult differential diagnosis. The other thing we are really expert in using very frequently mental health legislation. The Mental Capacity Act, we use on a daily basis. So we do capacity assessments, we do best interest meetings, we look at power of attorney and what rights in legal terms, various members of the family of the patient has. We obviously do mental health act assessment. A lot of our patients have issues with safeguarding, and they may be involved with many agencies. They may be involved with the police. They may be involved with social services. They might be issues about looking after, grandchildren. So we involve with schools, and we have a good cross-agency working in old age because of these complexities. So this is what makes us a little bit unique. The other thing that happens in old age psychiatry, we are very good at facilitating non-clinical, or as we currently call them, extended roles. So almost every doctor in old age psychiatry, if they want to, they will be involved in research, quality improvement, service development. So you will have the power, if you feel the service provided is not ideal, to change it. You will be empowered to speak up. They will be empowered to do what's best for your patients. Many, many doctors in old age psychiatry as educators, both consultants and SAS doctors. And I am sure that you all have met SAS doctors who are foundation clinical supervisor and educational supervisors in your placements. And one of my current roles is I'm an associate dean at NHS England WTE, which everybody calls the deanery. And I work very closely with the director of the foundation program in East Midlands where I am based. You can also have representative roles. So many of the people today will have roles within the College of Psychiatrists. Other people decide to follow their interests which are not linked to the medical career. There are writers, athletes, people with business interests, people who volunteer here and abroad, people who dedicate their time and expertise to charities, including to charities supporting the mental well-being of doctors. So I hope that when I give you this summary, you realize that working in old age psychiatry allows you to be the well-rounded person you are. It doesn't mean you just have to like one bit of the clinical work. Next, please. So I'm going to tell you a little bit about our expertise. We will be the experts called upon if there's a cognitive difficulty. Our services start at 65, but we do look after people with cognitive difficulties who are younger. The cognitive difficulties that we see range from normal aging and people who are anxious about getting older and am I losing my memory, to age-related impairment, and to mild cognitive impairment and dementia. We very often see people who present as dementias, but actually they have something called pseudodementia. There's a medical cause that temporarily, until it's treated, can cause cognitive deficits. Next, please. As you can see here, the process of moving on either through normal aging or gradually towards dementia can take many years, and every person is different. The way they present, although there are patterns and we use pattern recognition to diagnose, it can take many, many years. We are with people in the whole of this clinical journey, and the supportive services available to people make their quality of life significantly better. Next, please. One of the things people don't appreciate is that when you have a cognitive disorder, there are quite a lot of non-cognitive symptoms. And these symptoms cause the most distress. And we will be treating this with non-pharmacological mainly, but also with pharmacological means. Next, please. I will show you all this slide just to tell you that there's common and rare forms of dementia. And quite often in a career as an old age psychiatrist, you will see 10, 15 types. Of the rarer ones I have seen is CJD or mad cow disease. And you see people with dementia syndromes that improve significantly with neurosurgery when they have something rare that's called normal pressure hydrocephalus. So not everybody who has cognitive disorder will progress and be just managed rather than improve. Quite a few people can improve. Next, please. So the assessment of cognition we do is really comprehensive. One of the great things about psychiatry, I'm sure you got by now, is that we have the time to sit and really take an interest in the patient, their journey, their symptoms, the things that really affect them, the context of their life. Next, please. And we also look at quite a lot of medical things. We look at ECG, we look at brain imaging, and we do like a behavior chart. We do like to know why a particular problematic behavior starts, how does it get escalated and de-escalated, and how long the effect of whatever intervention you applied lasts. But we're really keen on consent. We want to know that if somebody is referred for cognitive assessment, they consented to it, because patients have the right not to know if they don't want to know. We work to the benefit of the person, and we always consider a lot of ethical issues about a person who is, for example, at the end of life for some other condition, being referred to be also diagnosed with dementia, where their life expectancy is likely to be limited, and this diagnosis may not be of any benefit. But we also consider the person's wishes. They will have current wishes, and they will have a belief system throughout their life, which they express to the loved ones. And we like to take all of this into account. So what we do is holistic management plans that take into account all these factors. Next, please. We love very much to work with imaging consultants and other colleagues. And I will whiz through some of the slides to show you how interesting it is. CT scans, MRI scans, and other more specific types of scans that we look and order for patients and interpret as part of our work. So this is a CT scan comparing the brain atrophy in an Alzheimer's patient compared to a normal patient matched for age. Next. We can see the shrinking hippocampus, both with age and with the varying degrees of cognitive impairment. Next, please. There's sophisticated scans called PIB scans that show the difference between aging and Alzheimer's. Next. We look at vascular dementia and how you see it on the scans. We often look at MRIs. Next. And if you have somebody who has fairly common type of dementia, called Lewy body dementia, on occasion we do DAT scans, and we look at the very striking finding when somebody has dopaminergic difficulties that you see in the scan. Next. Frontotemporal dementia will have different findings on between normal and the condition. Next. And SPECT scans will show you the difference in activity in the brain between various conditions. Next, please. One of the things we also discuss with families is the genetics of conditions. So we will see younger people with Alzheimer's disease and younger people with frontotemporal dementia. And for those people, there's a strong genetic link, and transmission can be autosomal dominant. So we get involved in those kind of discussions and genetic counseling. In the late onset Alzheimer's, who's more common, the genetic testing is already available commercially, and some people are interested in it, but there's significant ethical issues about what you do with the outcome and an implication for the life thereafter. There's also biomarkers, but they're not currently in current use. The most reliable current ones are from spinal fluid, but there are some blood ones which are less specific. Next, please. So following a diagnosis of a cognitive disorder, we then provide a significant amount of support, education, activities, and stimulation for patients. Medication and the medical model of treating it is just part of it. We work in a very highly functional, multi-skilled professional, multi-professional team in all-age psychiatry, and it benefits the patients, and it makes for a very interesting work environment and a very happy, friendly team. Next, please. So for the non-cognitive aspects, we often see that non-pharmacological, so no medication, works better. And I put this thing here because I think you will recognize this from the ward environments that you will be working on. Next, please. And medication we use only if necessary. Next. So the other thing we do, we have expertise in these legal frameworks, capacity assessments, deprivation of liberty safeguards. We are we always focus on the family and who has the power of attorney, and understanding this concept is really important for you as a foundation doctors to know what legal powers of overriding advice people have. And so I recommend that you ask people who are under your care who is their power of attorney. Next, please. So in summary, all-day psychiatry is the best subspecialty. There are several subspecialty you may initially appeal to you, and I think you should try them. Portfolio careers are common in psychiatry, so you can be the well-rounded person that you want to be and have interest within medicine, but not clinical, or outside medicine, that actually gives you pleasure and that will keep you in the career in a sustainable way. But the choice of route you take is yours. And if you come to psychiatry, we will support you whatever choice you have. If you're in a training program, a locally employed doctor, SAS doctor, consultant, if you're substantive or you're locum. And the last thing to say to you is that if times are tough in your career, you will want psychiatrists with the skill to empathize and support you, to be your colleagues. And when times are good, psychiatrists are very good to inspire you and be the wind in your sails. So I hope lots of you become psychiatrists and we meet as colleagues in the years to come. Thank you very much.
Thank you so much, Lily. I think that was a great last slide, but I hope you'll be able to join us for questions, because I think there's a couple of questions in the chat which I'd really like you to answer to. Chris and, oh gosh, I can't see if Filippo is still around. Oh yes, Filippo. Chris and Filippo, will you switch on your cameras as well? If I can start off with Chris, there's a question specifically about medical psychotherapy, but there's a question after that, which I think all of us, I suppose, can talk about. So Chris, the first one was the advantages of training in psychotherapy as a consultant psychiatrist, and how much are you involved in the delivery of psychotherapy on a day-to-day basis?
Okay, well, this is your main job as a medical psychotherapist is to make sure that the psychiatry trainees get their requirements for their training. That's the reason that you are employed by trusts rather than just getting and other psychotherapists. So that bit of your job you have to focus on. But the clinical part of your job is really up to you. You know, some people will, I like seeing patients. So I will have 3 clinics of 4 one-hour patients in a week. I will see 2 or 3 assessments or consultations during that same week. So I see more patients than some of my colleagues. but it's really up to you. If you want to increase some of the other stuff that you do, some of the management stuff, then you can do that. I don't think it's as satisfying a job if you don't keep a reasonable high proportion of clinical input. It keeps your skills sharp, and so I enjoy that side. So.
And there's a significant, I suppose, degree of supervision and training, even more so than in other specialities. A lot of your time, I guess, is, if not directly talking to patients, but talking about patients to trainees, isn't it?
Yes, I have fewer clinics in psychotherapy than I did when I was working as a general adult psychiatrist, because there's so much more training and supervision really that's required. So, which is very enjoyable.
Thank you. So this is a question, I think, as I said, for all of us. Lily, I suppose if you could go first, and also Filippo as well. The trainee want to know, are there any other alternative options, opportunities that the completion of the first years of core training provide? Now, I asked them to clarify a little bit, and what they're wanting to know is, if you sort of finish core training and then decide you don't want to go through the traditional higher consultant route, what else can you do with that, and how else can you do it? So all of the above that you've mentioned, so kind of working in NHS, research, education, different routes and roles around psychiatry, still relevant to the field. If you still want to be kind of in mental health, you don't necessarily want to be a consultant psychiatrist. And some of that we're going to visit this afternoon. So we're definitely going to be talking about those things this afternoon with some of the speakers. But Lily, you sort of mentioned the portfolio career, didn't you? And I think you've got a great example of it yourself. So why don't you start, and then maybe Filippo after that?
So, I mean, there's lots of jobs in psychiatry, and the flexibility of the career is such that you can, if you decide one path and it's not for you because of life experience or you have other interests, you can then move from one path to another. So it isn't the either training or LED SAS career. You can actually move across. And many people, I'm sure Filippo will talk about this, many trainees kind of move across these days. So in terms of not being into training, at whatever stage in training you decide to step down, there are locally employed jobs. And what these are is, if you're fairly on, like you on this call are, you won't be able to get a SAS job, which is a permanent national contract career, because you will need 4 years of medicine experience, at least 2 of them in psychiatry. So initially, if you decide as a foundation doctor that you want to try non-training first, you will need to get a temporary job called a locally employed job. And people call these jobs all sorts of things. When you get your 2 years, then you can apply to be a SAS doctor. Now, from a SAS doctor or from an LED, you can move back into training at any point you want. It's good to have a portfolio and show, because some of your experience will be recognized in a training program. But if you decide to completely stay out of training like I did, then you can progress, and specialty doctor careers are very structured. They have 2 thresholds. You become more senior and an independent senior doctor. And there's now, since last year, even higher, sort of more senior SAS doctor called a specialist. And these people are autonomous practitioner with lots of experience, skill, and knowledge. So if you don't want to become a consultant, there's a very well-established route. Is this a small route? No. There are 3,000 SAS posts in psychiatry in the UK. And people that come into SAS come from a wide variety of interests and culture. It's a very diverse group. There are some barriers to progression because it is not traditional, but psychiatrists, I find, they are there to smooth any obstacles you have. You will have colleagues who will help you along. So if you're interested in this, find out a bit more about it. And in particular, find out about it if you at any point are considering leaving medicine. Please don't. come and join us for a little bit, because you'll see that actually you might enjoy not having to move around every 4 months, because these are normally permanent job in one location. If you have a child who's disabled, if you yourself have health problems, you will find lots of your colleagues will choose these jobs and this career, and it's really enjoyable. I've done it for 15 years. I plan to do it for many more.
Thank you so much, Lily. Thanks. It's a very quick, but I think lots of content there. So I'm glad it's being recorded so we can play it back afterwards. Filippo, I don't know what stage of training you're at, but I guess that in substance misuse, for those of you who don't know, there are a lot of substance misuse posts which are in the NHS, outside the NHS, and straddle both public and private sector. So yeah, again, working in substance misuse, there's lots of different opportunities available.
Yeah, to be honest, I'm doing a placement here with the supervision of Professor Baden-Jost, but I'm doing my traineeship in Italy. So I am what is a senior. We actually don't have a senior doctor in Italy, but I am a trainee at the last year. So I have to be honest, I don't really specifically know which are the opportunities in those cases here in England, since I'm completing my traineeship in Italy, and I'm doing only a placement here. But I guess another opportunity maybe could be research. I knew one trainee, one senior trainee in ophthalmology, and he told me like he wanted to do like a PhD during the traineeship, and I think it's another opportunity. So there are some research opportunity in these fields, or maybe a master. So but honestly, I don't specifically know because I didn't do my traineeship here.
I'm sorry apologies for putting you on the spot, but there are.
If you have some gambling related or addiction related questions, I can try to answer.
Of course. Chris, now I know you've moved around a lot as well, haven't you? Well, although it's not been quite a portfolio career, I think you could also talk to kind of sort of how, I guess, having that sort of dual adult psychotherapy role allows you to work wholly within one service, across two services, or actually create something more bespoke for you.
Yeah, so a lot of, in fact, getting a dual training is very helpful whatever you do. So if you decide you can do a medical psychotherapy dual training and not work in medical psychotherapy, and it will stand you in very good stead for dealing with, for example, patients with personality disorder that you see, on a day-to-day basis. It's very helpful. I've got colleagues who work in early intervention in psychosis and liaison psychiatry that have also done, and forensic psychiatry that have done medical psychotherapy training. So, it's...
And eating disorders. I'm not going to eating disorders, really, really important as well.
Yeah, so there's various options, and you can move. That's the other thing, is if you want to try something different, you have options. Even when you've got grey hair, you can move from one field into another. It's the doors aren't locked and bolted, and it is helpful if you've got a choice of different careers. A change is as good as a rest, as they say sometimes.
And I would, as I sort of mentioned earlier, I would totally agree with that. I'm a consultant, but I have moved a lot as a consultant. I trained in joint forensic and adult, intending to work in forensic or low secure forensic, but kind of soon decided that's not what I wanted to do. I moved back to general adult, worked as an inpatient consultant in home treatment and crisis services. I worked for 4 or 5 years as a eating disorders consultant, hence my interruption of Chris to point out, and eating disorders shares a lot with older adult psychiatry, with the emphasis on patients' physical health, obviously, as well as their mental health, and holding both of those things in mind. It was really, really important. And currently I work in an assessment service. But so all of these, in answer to the question about sort of what can you do if you want to stay within psychiatry but not exactly take the traditional route, there's all of that open to you. You don't have to work full-time at all. I work less than full-time. Most of my colleagues work less than full-time, and that might be for caring reasons. You might have dependents, or because you actually that's how you want to work. But it also then gives you the flexibility, if you don't work a sort of traditional 9-to-5 week, to take your interests where they lead you, whether that's research, education. The people that you'll hear from this afternoon have taken it in more creative directions. A writer, performers, all those kind of things. It leaves you open to pursue the other things that give you joy and pleasure in your life as well. So I would say that when I entered medicine was very much a vocation. It was very much about what you did with your entire life. And over the last 20-30 years, that's changed. And I think there's lots and lots of good role models, great examples of people who can still work in mental health and are still committed to mental health, but also choose to do other things allied to that. And you can create that for yourself as you move through training, or as you develop other experiences like Lily has done. So I'm aware of the time. I can't see if there's any more questions in the Q&A.
There's a really important one about threatening work environment. I think we should address.
Yeah, might be one that I answered in text, but I thought it's also good to talk about it live. So,
and there was also a question. Sorry, and this is my mistake. Somebody asked very early on about. Hold on a second. The interest in psychiatry. One of my main queries is about how staff protect their own personal, mental and emotional well-being with particularly heavy caseloads. Do staff suffer from mental fatigue, and any advice on maintaining balance? Now, I'm very aware that we've got Helen on. I don't know if she's available to come on to that, but we do have a whole session this afternoon, particularly from Doctors in Distress, and talking to us about that in particular. But seeing as we've got sort of Lily and Chris on, you might want to kind of have your own thoughts about that.
Yeah, let me tell you my thoughts. I think that people, when they think of psychiatry, they think you're going to deal with dangerous people and lots of violence all the time. And those things do happen. They're not as common as you imagine. And to see somebody transformed, you will have skills of de-escalation, and you have skills of understanding people's expression of distress. That will de-escalate situation pretty well. Now, if you think on the other side, you're somebody anxious and this worries you, your team, your multi-professional team, are there to support you. If you have, you're worried about physical violence, if it's emotional burden. One of the things we do as psychiatrists that you don't see in other specialities, we all are part of peer groups. So we are in group of 8 to 12 psychiatrists. We have college asks us to meet them 4 times a year, and they provide a professional friendship group where you can rely on in every possible way. It's a already there network of people that you can call upon, and I found this amazing when I moved into psychiatry. It's an amazing resource. So I don't find the threatening environment, I can't stress enough that what you think will happen is possibly unlikely to happen.
Thank you, Lily. Chris?
Yeah, I just was going to echo what I put in the. So there are opportunities for emotional support. We quite often run groups called like balance groups, for example, where people can talk about how patients made them feel. And instead of just thinking, I need to survive this, it actually then becomes more information, and you can start to use it to make more sense of what's going on. And I pay to be in a balance group myself. I was in it last night after work. So I obviously think they're useful because it keeps me going. But I think the work-life balance is really good in psychiatry. You know, I've got hobbies. I'm going out mountain biking this evening. I'm playing board games tomorrow evening. You know, you can fit quite a lot in your life. It doesn't spill so much over, you know, you can finish at 5 o'clock mostly, you know, in psychiatry in a way that perhaps in other specialties is trickier, you know.
And I would add on to both what Lily and Chris said, as well as things like peer groups and balance groups, there's a wider culture of reflection. And I wouldn't say that's 100% everywhere, but certainly in the workplace that I have and the teams that I've worked in, more often than not, there's a really kind of within the teams and within sort of departments, there's a real interest. Like Goodwin said, right very early on, there's an interest in consultants kind of in their trainees. How are you doing? When they ask that question, they actually want to hear the answer. But that's similarly for me and my consultant colleagues. You know, when we ask, how are you doing? People want to know the answer, and we will sit and think about it when people are struggling, people reach out. And many of us are involved in mentoring, coaching, but also informal support as well. I mean, I would say most of us go into psychiatry because we're interested in people, and generally we like people, and usually we're a good bunch. Not everyone, I don't want to generalise. We're generally a good bunch, and if you choose your colleagues well, then you will end up with a good bunch, and that in itself, really importantly, I work with people who make me laugh and kind of appreciate my sense of humour. It's really important to kind of go to work with a smile and leave kind of finding, you know, medicine, there's a lot of dark humour, and, you know, you need to find people who share your sense of humour as well. I think that's very important. Now, I'm aware we are coming up to 12:15. There are a couple more questions in the chat, but I'll probably answer those. I'll kind of write the answers to those. I just want to kind of finish this morning's session by saying thank you to all our speakers, both sort of Lily and Chris and Filippo who stayed, but also kind of acknowledging that those who couldn't stay was mainly because they're so busy, and I'm incredibly grateful that they were able to spare some time to come and talk to you all. Before you run off for lunch or whatever you're going to do for the next sort of half an hour, 40 minutes, we have got some really, really interesting speakers this afternoon. Tade Thompson, who's a consultant psychiatrist and award-winning novelist, and Barry Mullins, who's kind of converted from psychiatry but he's also a staff grade doctor as well. You might want to have a think about what you've heard this morning, what kind of things you want to know from the people this afternoon, whether that's going to impact how you hear stuff this afternoon. And then I am doing a longer session with Professor Steve Peters. Some of you may have heard of him, some of you may not. He is the author of a number of books, including The Chimp Paradox. He's worked in the NHS, he's worked outside the NHS, he's worked for the British Olympic Association, and is kind of well known for his work with many sporting stars and celebrities, as well as his NHS work. So I'm going to be doing a little bit more of an interview with him, like Professor Bowden-Jones did, because there's so much to talk about. And it'll also be an opportunity for you to put your questions in the chat with him as I ask him questions from me, but also hopefully from you, what you might want to know about somebody who's maybe towards the end of their career, still enthusiastic and has done loads with it. So all that stuff about portfolio careers, doing something different, keeping lively, keeping interested. Like Chris said, all those people in their 80s who are still turning up to conferences and still loving it. How do you get that? You know, I think that's really, really important. I'm sorry we didn't get to that, Chris, because I thought that was really interesting. You know, I think that's brilliant. And, you know, we all have times where we think, gosh, we struggle, and how do you keep going? And you look at those people, you think, how are you still here and still so full of life? So that's something else to think about as well, something to leave you on. If you've got a picture of that, again, Chris, stick it up. If you can't, don't worry about it. But that's a lovely way to leave it. Enjoy your lunch, everyone. I'll see you back at 1:10. 1:10, everyone. We'll see you back. All right, take care. Thank you. Welcome back, everyone. I hope you've all had a chance to have something to eat, drink, stretch your legs a little bit. It's not very sunny here where I am, but if it's sunny outside, I hope you've had some fresh air and also a chance to think about our speakers for this afternoon and any questions you might have. But to welcome us back as with the opening address, I am delighted to welcome Dr. Tade Senavaratne, who's the Registrar of the College since 2020. So the Registrar, for those of you who don't know, has a role in sort of overall responsibility for policy, public education, revalidation and membership engagement. But more than that, Trudy is a massive champion for perinatal psychiatry and women's sort of maternal mental health. In her role, she's been chair of the National Clinical Reference Group, chair of the perinatal faculty, and in 2019, she was awarded an OBE Services to Perinatal Psychiatry and the President's Medal for the Royal College of Psychiatrists. In 2023, she was appointed to the expert advisory group that supports the Princess of Wales work into early childhood. So I'm really, really pleased that, I know Trudy's really busy, so I'm so pleased she's been able to make the time to speak to us today. And I'm going to stop talking and let Trudy talk now. Thank you, Trudy.
Artie, thank you so much for inviting me. It's so exciting to be here. Thank you so much. And so we're slightly humbling to hear sort of one's own achievements, but you know what, I've moved into a space where I now celebrate these achievements rather than thinking, oh god, that's embarrassing, because actually we should celebrate what we do. And you know, I'm celebrating here with you guys, all of you who are pursuing, some of you might be further down the road and much more sort of solid in your thinking about which specialty in psychiatry you might be going into. Others might be a bit less sure about where you're going to go to. But just well done for getting here and thinking psychiatry may be the one for you, and you're going to, you know, run in this direction. Just to say, I know you've had some brilliant speakers already, and I just want to add to some of that. I could speak for hours about how passionate I am about psychiatry, but I've only got about 7 minutes left. But essentially, you know, having gone into medical school, actually wanted to be an artist, go to art school, but wasn't allowed to do that one. But anyway, having gone into medical school, thought I was going to become something like an obstetrician or a surgeon. And it was right at the end of medical school that the psychiatrist, and I went from working in the HIV wards in Bart's Hospital, St Bartholomew's in London, where I was training, and it was a sort of late 80s, to East London, where the wards were full of people with very psychotic illnesses and so ill. But I was so shocked by how awful the wards were, how terrible, and how behind the rest of medicine psychiatry was. However, the psychiatrists were the most amazing doctors I met. And that was my first sort of road to Damascus moment, which is that actually the brain is the most important organ we have. And if it does not function properly, we have absolutely no quality of life. So that was my first pivot. Then my next, and I thought, right, that's it. I'm no longer abandons everything else in medicine. I also thought actually psychiatry is behind everything else in medicine. You know, the drugs were the least well developed, least amount of research funding going into it, the estates. So the actual wards that patients sat in, I thought, well, they look dreadful. This isn't good enough. And anyway, on I went. And then on my journey, I went back to train with a psychiatrist who sort of essentially told me the brain's the most important organ we have, and worked on a female psychiatric ward in Hackney. Most of it was women who had severe illnesses, maybe depression, suicidal, or mostly psychotic illnesses. But then there were 2 tiny beds at the end of this female ward, which was for women with their babies. And I watched a whole series of women with really florid psychosis after childbirth, but they were being cared for by their babies. And remember thinking, wow, this is amazing. How is this even possible? What about risk issues? Don't they hurt their babies, kill their baby? All of these, you know, naive stuff. And realize that actually, of course they don't. They get better, and they get better with the right sort of help. And I then was lucky enough, having done a little audit, and I encourage you all to do bits of audit and research and QI projects as you move forwards, because actually it was on the back of a very simple audit of that 2-bedded ward, and I'd moved on to become a CT or SHO trainee, that I got to go to Italy, and on the back of that met my future mentor, who was the only professor of perinatal psychiatry at SLAM at South London and Maudsley, who ran the mother and baby units. And I got chatting to him, and in that conversation, because nobody wanted to speak to the professor, in that conversation, realized that actually for our mental health as human beings, and was quite a profound realization for me at the time, and it still is actually, I've been in the specialty for 30 years now, that actually for our mental health as human beings, we start right at the beginning. So the moment the sperm hits the egg and we start developing, every day is critical. And actually we have to look after the woman's mental health, because how she is, how they are, how the mother is, if you like, has a direct impact on the developing baby and the developing fetus. And so it seemed to be a perfect place to intervene, to make a difference, to support the maternal mental health and to support the fetal mental health, if you like, and then the baby when the baby is first born. And remember thinking, gosh, you know, as a psychiatrist, you've got this tool of things we can use. You know, I can use biology if I want to, by treating people with medication. Gosh, in some severe cases, when women are catatonic in pregnancy or afterwards, I use ECT, electroconvulsive treatment, and people get better. There is a whole range of talking therapies that we can use, perhaps with the mum, with the partner, or with the family. We can use really interesting mother-infant video work to help people's mood improve, but also show how the baby gets better. There's you're securing the life chances of the child. And also everybody has babies. So actually in psychiatry, within, say, perinatal psychiatry, but you do it in all of psychiatry anyway, is that real privilege that we get to work with absolutely everybody from every different background, every different society, every different culture. And as time has moved on, actually the whole issue of, you know, the diversity of who parents are and how babies are conceived, and that spectrum continues to change. We no longer think just about mother and baby services, we think about parent and baby services. So it just continues to grow and grow and change. And it's a real privilege when you have, when I was chair of the faculty at the college, and that's the other thing I really urge you to do. So I'm delighted you're here as foundation trainees. I really encourage you to continue engaging with the college as you go forwards. The college provides a huge amount, and I first really got involved actually as a trainee at the college many years ago, and I've somehow stayed in with all the various groups and committees and the trainees committee, interfaculty, some of the special interest groups, of whom, which there are so many. Psychiatry is a very creative specialty. So I've just created an artist in residence for the college. So there are special interest groups around the use of arts in psychiatry. I know you've got speakers who are writers and artists and make music or make films. So it lends itself really to a really interesting career. I mean, I never get bored with what I do, whether it's my clinical work or my managerial work or my research work or my education. And the college also offers this enormous breadth of activities that you can take part in. So really encouraging you to take part in the special interest groups, in the various committees, faculties as you move forwards. And I guess on that note, I'll listen to everything that everyone has to say today. But going forwards also, if you do want to get involved in more things at the college, please just come and ask. If you have ideas of things you want to do, you can do that. But more importantly, I think I mean, for me, it was really good that I was lucky to find a mentor in psychiatry by accident. Well, the psychiatrist that inspired me, it was brilliant that actually I followed my heart and my passion into psychiatry. I lost my mentor in perinatal psychiatry. He sadly died he developed a relapse of a cancer and he passed away. However, what I had with him over a 4-year period when I went back to be his research registrar was so incredible that I've sort of continued the passion that he had. And that's where, you know, Artie very kindly talked about work I've done elsewhere and working with people like the Princess of Wales now. That passion has really driven me in a particular area of psychiatry. And I really hope that, you know, when I'm no longer, it's a bit morbid really, but when, you know, when I get to not work anymore, that there will have been some sort of gentle nudge or improvement in the way mental illness, mental health is thought about in our world in areas like perinatal psychiatry or mental health. There's so much we have to do still in psychiatry. There's still so much stigma, there's still so much shame. We still have to discover bucket loads, you know, loads more new drugs to innovate and think about. Lots more talking therapies, lots more thinking about how we look after people depending on which culture and background and sexual orientation they come from. So, you know, you will never, ever get bored. So just run with whatever really drives your passion. And that's all, Artie, I wanted to say. I think I've run out of time, haven't I?
No, that's absolutely fine. I just really enjoyed listening to you talk, Trudy. So if you can talk for another kind of 15, 20 minutes, half an hour, that'd be absolutely fine with me. I know you need to go. So just, again, chair's privilege. I just wanted to ask you a quick question.
You can ask me you can ask as many as you want, because I think I've been allowed another 10 minutes before I start something else. They drive you hard at the college, by the way.
I was going to say that we want our money's worth out of you, Trudy, now that you're here. In your time sort of working as a perinatal psychiatrist, you've been kind of witness to a massive increase in interest, funding, awareness of services for perinatal. I know there's obviously a huge way to go yet, but you know, when everything else around us, it feels like everything else is being cut. I was just wondering what that felt like for you, to be witness to be part of that, to be leading that, but also to be present, kind of the before and the, not after, but certainly the during.
During it still, we're still on that wave, actually. We're still on that wave. So as I said to you, when I entered the specialism, which was back in 1994-5, and Trainee sadly died in 2000. And I remember him saying to me, he said, Trudy, and I trained at, you know, went to do research registrar at King's and Maudsley and Slam and the Institute of Psychiatry. He couldn't get to Parliament. I remember him saying, wait, I can't go, but I'm trying to get the politicians to understand this is important. You go, you pretend it's me. And he happened to be in, like, he was an Asian man in his early 60s. I was a trainee in my late 20s or early 30s, something like that. And so I remember going sort of slightly sort of daunted into Westminster, presenting why perinatal mental health was really important. And then actually at that time, there was only one professor of perinatal psychiatry at SLAM and one consultant psychiatrist. We now have 12 psychiatrists at the Maudsley in this. That's how much it's changed. So it feels, in answer to your question, it feels amazing, but it was a real struggle. And actually, you know, things folded and died because there was no immediate succession planning to Trainee passing away. Lots of people not really getting it. Lots of midwives, you know, obstetricians, others not really understanding, even psychiatry not understanding why perinatal psychiatry was important. So I quietly just chugged along. I started a PhD actually, and when Trainee died, I had nobody to continue supervising my PhD. So I chugged along doing it on my own for a couple of years. Genuinely couldn't find a single person nationally that could supervise my PhD. And eventually I abandoned it on the back of my second child arriving very early. But no, it is amazing. But what it is that if you are passionate and care about something, you just keep going. And that's what I did. I effectively kept going. I became a consultant, told the system where I was working at SLAM, you needed more consultant time. I was lucky enough to be appointed into one of those roles. I was part of an appointing process where I got some really brilliant academics in SLAM, also doing clinical sessions, people like Carmini Parianti, Paola Dezan, and Louise Howard later. They came in and we just kept going. We took a proposal to NHS England, and eventually 16 years later, gosh, it was 16 years later that, I invited politicians to come and see the service. And I remember when David Cameron announced that there was going to be this release of £365 million for the expansion of mother and baby unit beds and community perinatal services in England. I had a chill. I definitely had a moment of, like my spine chilling really, and thinking, wow, we've got there. We've got there. And then on the back of that, the other devolved nations also invested some money. Then Brexit happened. Everyone's thinking, oh God, perinatal money and Brexit happening at the same time. It's extraordinary. And I think one of the other things to share is that it's rare for there to be a moment or a wave in psychiatry. But when we're on a wave, it's really important to jump on it and really enjoy that wave, because at some point that wave will go. But I think in mental health and mental illness generally, we are on a wave. The Royal College of Psychiatrists is on a wave. The importance of psychiatrists is on a wave. Yeah. There is no more important time actually in history than now for the importance of how important psychiatry is, and how important psychiatrists are, and how important our mental health is. So we are on a huge wave now. Politicians come to us as like the go-to college for so much stuff now. We're in the media as a college in a way that we never were. If I go back sort of 15, 20 years, it's hardly ever talked about RC Psych in the news. And that's all gratitude to Simon Wesley when he was president, actually, that we started to move that. So I would say to you, just enjoy being, you're already thinking about going into a career in psychiatry. So I would just say, just keep going and be on the wave of actually the world recognizing that our mental health really is the bedrock of who we are, and what you can be any psychiatrist you want to. That's the beauty of psychiatrists. You can, you have your fundamental training, but then you can be a biological psychiatrist, a psychological psychiatrist. You can have principles of health and well-being, eating well, and exercising well. So you can have all of that. You can have the complexity of the diversity of who we are, and you can bring, creativity and arts into all of this. I mean, every single art, music, film, reading, writing, drama, all of that. So yeah, it's a very long answer to it.
No, I think there's a couple of things I wanted to pick out, especially for foundation trainees.
Yeah.
Right at the beginning of the day, I talked to them about, yes, this is about, I want this to be a positive event about careers, about the breadth, about the depth, about the joy of working in mental health, but also bearing in mind the context of what's been going on in the NHS the last few years, not being, I guess, blind or impervious to junior doctor strikes, the context, hours, things like that. And I think there's some really important things that I wanted to highlight for the trainees, and what you've described, that things were tough and have been tough, and what seems to have kept you going is a belief, a kind of your values around whether it was perinatal mental health, about sort of early years, childhood mental health, that kind of holistic approach to individuals as well as healthcare systems. And although things may be tough, there's something about personal values as well as the support systems. You talked about the importance of your mentor, but even when your mentor wasn't available anymore, how you kept going and other important people in your life. So thinking about those things early on in people's careers, and where they are now and how you find that. And what we've talked about earlier in the morning was how supportive psychiatry, the culture is, you know, in the workplace, amongst colleagues, and maybe, I don't know, I'm sure you found that as well, Trudy, that although you may have felt very alone at certain points with kind of being the only perinatal psychiatrist, there's certainly a lot of support around within sort of departments and teams, I think more so than other specialities, certainly. Definitely.
I think the family of psychiatry is really wonderful, actually, and that's a real strength. And you're absolutely right. There are so many challenges in the NHS, and, you know, I'm just thinking back to a time where, you know, I needed to do 100-hour weeks and such, and, you know, back in the 90s and things, as a junior doctor, having no rooms to work from, and still place people not having, you know, colleagues not having rooms to work from. We've been through a pandemic, but actually, you know, if you have the right people around you, first of all, you know, really choosing what your heart wants to do, and just gently moving forward with that, making sure the right people are around you, and that includes your correct professional network, asking questions, not being frightened to sort of ask questions to everybody that's around you. Sometimes I think doctors are a bit frightened because we're all a bit perfectionistic, aren't we? And we don't sort of ask for what we need. And obviously your loved ones and your family who are around you, you know, are a critical part. And we often talk, and the other important bit is really enjoying it and having fun, because actually medicine, psychiatry, mental illness, there are dark sides to it too. You know, we deal with really difficult stuff. We deal with suicide, we deal with infanticide, you know, we deal with, you know, homicides. They are not easy things to deal with. So there's a tough part of psychiatry too. But equally, you know, we also have that ability to integrate that biological, psychological, social and cultural stuff. We can do research, we can educate, you know, these things that allow us to have these interesting portfolio careers as we move forwards. And we tap into those as we go forwards.
Absolutely. Thank you so much, Trudy. I really, as I said, I know how busy you are. You've got another meeting to go to. So I really appreciate you staying a bit longer, having this conversation, because I think that richness really adds to events like this, especially online. So I'm really grateful that you've been able to stay a little bit longer, have a chat around things as well. So thank you ever so much.
Now, thank you, Artie, and enjoy the rest of your day.
Thank you so much.
Bye-bye.
There's been a bit of a change to the programme for attendees. We were supposed to be hearing from Barry, but unfortunately, I think he's had connection issues. And so we're going to be in a slight change. Anne Paul from Doctors in Distress is going to come to talk to us next. She was due to come to us, come and talk to us later this afternoon, but she's very kindly agreed to step in now. So thank you so much, Anna, Anne, and I'll hand over to you now. Thank you.
Thank you. I have to say that was a bit of a surprise to me. Can you hear me?
Yes, we can hear you.
Okay, thanks. I wasn't aware that I was going to start now, but that's absolutely fine. I don't mind at all. So it's great for me to be with the foundation trainees at RC Psych. For those who don't know me, I am Chief Exec of Doctors in Distress, and I'll tell you more about them, the charity, in a moment. But the connection with RC Psych is a long-standing one. I worked as a director of development for 5 years, so I am especially pleased to be invited back. Let me tell you a bit about Doctors in Distress, because Trudy mentioned towards the end of what she's just spoken about, she talked about some of the difficulties, the really hard side of the work that you will do if you, or shall I say when, you go into psychiatry, because honestly, I think it's a really, really important specialty, and there is so much changing, as Trudy said. So I can't see if my slides are up or not. I am having a bit of a problem. Can you see, Georgia, can you see my slides?
Not yet. So what I'm going to do, I'm going to share them for you. Is that okay?
Okay, that would be great. And then I'll just ask you to move them on, because I think it's not possible.
Can you see?
Yeah.
Perfect.
So,
Let me know when you want to
sorry
move.
about that, everyone. I'm presuming you can all see what I can see, which is the slide that says about us. Okay, so Doctors in Distress is an independent charity, and I'm going to probably say that a few times. We started in 2019 following the tragic death of Jagtib Sidhu, a consultant cardiologist who died by suicide. And his brother, Amanda, decided then that what he wanted to do was create a charity that would not just serve one person or be in the memory of only his brother, but would be there to serve all and support all doctors. Since then, we've expanded, and our service is to support all medics in the UK, so the 4 nations. And why am I talking to you about this at a foundation trainee event where we are really encouraging you to become psychiatrists? I have some of the best working memories of my very long career working in a college. So our aims are very clear. We're set up to promote and protect the mental health of all healthcare workers. So it's promote and protect. And then as a way of preventing suicide. And we provide a wide range of different methodologies. I'm not going to talk to you about all of them, because I think that it is just as easy. I'm pretty sure that the college is going to share the slides. But what we do is not just support individual doctors in groups. We work really hard to break down the stigma that Trudy just talked about, the absolutely persistent stigma that surrounds the conversation around mental health. And our aim ultimately is to normalize that conversation. And I'm particularly keen to be talking to you as we do with medical students, because if together we can break this down, the future of both medicine doctors and their patients will be more assured. Your dean, Professor Subodh Dave, is a trustee of Doctors in Distress, and he always says, happy doctor makes happy patients. I know it's very easy to say, but it is very true. Can we have the next slide, please? So let me tell you a bit about the different support groups we run, and these are just a top line. So in the last 4 years, we've completed programs that range from 10-week programs for doctors with long COVID, long before anybody was talking about long COVID. So one of our methodologies is a full 10-week program that is designed for professionals of the same grouping. So lots of work with junior doctors, foundation doctors. We've worked with Black doctors, doctors of overseas heritage, and so on. So it's a very wide range, and we're commissioned by either NHS groups or lots of different grant-making trusts to support the medics that we know are struggling through workloads that are impossible. So this is a way of showing that there is a lot of support out there. The program Doctor 1 in 4, also started by Subodh originally, is an interesting one because it's a webinar series, so much like this, where you're all in the background but can ask questions or put in the Q&A. And it's a conversation between an established, successful, usually consultant, but not always, doctor talking about their own mental health journey in conversation. And largely this is to show that there are bumps in the road. There will be bumps in the road for you, but talking about it helps. And we aim to show you that there are lots of doctors around, 1 in 4, I think it's probably more like 1 in 3, who have had a journey through their own mental health problems. And we just started the same because the stats for nurses are 2 in 3 are showing signs of stress and burnout. Interestingly, I'll tell you a little bit more about our creativity. Let me just stress, these are free for all healthcare workers. They're completely confidential, and they're all professionally, obviously qualified psychotherapists, group therapists. Can I have the next slide, please? Oh, by the way, please excuse me. I've got a cold and a chest infection, so if you can't hear me, I'm really sorry. I think I've talked a bit more about this. If you'd like to have a taster of it, go and check out Doctors in Distress YouTube channels. Those are the only of our programs that are recorded, because not everybody can tune in at the same time. Next slide, please. Next, oh, there we go. So just again, I'm focusing on this because this is the program that we've run for medical students and we've run for foundation doctors, and it works really well. So I would urge you that if you get to a point where you just want to share, want to understand that you're not alone, that going through some struggle, some stress, some burnout is probably happening to most. And if you can talk about it and talk with people, you are going to help to create the environment where people are not suffering any longer. They're able to come forward. Just check out our strapline, which is on this slide, which is, there is no healthcare without self-care. Another very facile thing to say, but how true it is. Next slide, please. So the peer support groups are around a topic quite often. So we have people who have long COVID. We've had a group of female doctors returning to work after a lengthy maternity leave, or indeed a lengthy illness, which is where the long COVID came in again. But not everybody can commit to 10 weeks, although most of the participants ask us to carry on for longer, which we can't do. But I can't do because of funding, not because we don't want to, but it's good to have an end-to-end program, which we evaluate, and we were able to share some of the learning. But there is also a drop-in for anybody who, on a Wednesday, anybody who wants to come and spend an hour, 45 minutes, talking, giving and getting that peer support. Next one. Next slide, that's it. So this is the one I wanted to follow on with what Trudy was saying, because we know that there is huge value in using creativity as a method of enabling people to talk and share their own feelings, work through some of their work-based pressures and home-based as well. So we offer reflective writing, and we have offered reflective writing, and reflective photography is one that's just started. And they're exceptional. The output of those groups has been really edifying for us. We're also starting to do things like walk and talk. We know that exercise helps, is a way of enabling people to talk. Cooking. Let me tell you about one of the things we're running, so watch out for it. We're going to be running a month-long campaign, fundraising and awareness-raising campaign in October called Eatober. And the premise behind that is when you're able to share food, you're able to talk and share some of your own feelings and thoughts. We know that this is helpful. Next one, please. I'm going to leave all of these, but I'm going to ask Artie or Georgia, whoever's doing the slides, leave these in the chat if people want it, or they can get them on the slides. What I'd really like to do is end with the last slide, please. Okay. I need to tell you, and I need to stress, that we're not an emergency service. Doctors in Distress works with people who are stressed and burnt out. And if you like, the pressure cooker is a really good analogy, just need to let some of the steam out. If you need help, if you need serious medical intervention, you're going to hear from the amazing Helen Garr later on, who will talk to you about national NHS practitioner health. But remember, you're not alone. You're working in an extraordinary discipline. I think anybody who goes into psychiatry is lucky. I've worked with fantastic psychiatrists. But I also want, because I would be remiss if I didn't, I want you to go on our website, look into Doctors in Distress. The more people who help and support us, the more we are going to reach those who actually do need us and don't know about us. And of course, we need you to help us raise funds. So contact our Doctors in Distress, or you can contact me as well. But do stay in touch with us, and if I can help in any way, I'd love to. Part of what we do is working with people like you. Artie, I don't know. I haven't got a timer on my screen, so I have no idea what you want from me now.
Perfect timing, and thank you so much. And I know you've had to move sort of kind of unexpectedly. You handled that beautifully, and I'm very, very grateful. Both of you coming to talk to us about Doctors in Distress, which is such an important organisation, the work, the nature of the work that you do, but also kind of putting some context around it for this is something that we've been touching on throughout the day, and we returned to about sort of a sustainable, we've been talking to the trainees about a sustainable career. The other thing that I'm very grateful for, and you've almost read my mind, the other thread that's been running through this is creativity. So quite a few of the people, our earlier speakers, talked about creativity, the importance of creativity in their personal lives, but also in their professional lives, and the importance of creativity in maintaining kind of resilience and our sense of self, which is so important for well-being. And it brings me really nicely onto our next speaker, Dr. Tade Thompson. So thank you, Anne. But I'd like to introduce Dr. Tade Thompson, who's a consultant psychiatrist and a writer. He's also the medical lead for Acute Pet Care Pathway, but that's not why we've asked him today. He's the author of 10 books, numerous short stories and screenplays. His work has been won or been nominated for multiple awards. Some of you may know his books. I do. That's why I was so excited when he's coming to speak to us. Rosewater and the Murders of Molly Southbourne are some of the more well-known books. I have to say I'm a massive fan, Dr. Thompson, so I'm so pleased that you've come to talk to us about kind of careers in psychiatry, but also how to broaden your career and think about other things as well. As I said, it's something we've been touching on throughout the day, how to have, whether it's a portfolio career or creativity, and to intersperse that with working in mental health. So I'll stop talking now. Thank you.
All right. Well, hello, everybody. I'm very grateful to be here. I'm flattered that I've been invited. I don't have slides. I don't have anything to show you in that regard. And I would really welcome questions. I know even though it's a really short period of time, but, if you have questions, maybe Artie can get those questions and then send those questions and, actually voice those questions. I'll say a little bit about myself. I didn't start out wanting to be a psychiatrist. I actually started off, from medical school, my real aim was to become a pediatrician or an ENT surgeon, because those were the subjects that I really excelled in at school. But I realized when I started doing ENT surgery that I didn't like slime, and I hated breaking into the maxillary sinus because there was that crack that happens, which I really found distasteful. And with pediatrics, I actually loved the kids a lot. I just did not really like I didn't like the parents complained like all the time. Anyway, there was a line from that to, I tried other departments, I tried A&E and all of that. I just wasn't feeling, I got bored really. So I ended up taking some time off to think about it. And a friend of mine said I should try psychiatry, which I didn't like as a student. But I did a 1-month clinical attachment in the hospital in Bedford. And I found that I really enjoyed it because everything that was happening was individual to the individual patient. So if you get a chest pain, if you're in A&E and you get a chest pain, what you get is a chest pain protocol, you follow that. But with psychiatry, it's individual. Each patient is a brand new person, is a brand new book, and has, really needs a bespoke kind of treatment. So I've been a psychiatrist since 2006, and I've never looked back. I've never felt like looking back. How does that link in with creativity? Well, you're going to need creativity in no matter what for a well-rounded life. And it doesn't have to be writing. It can be writing or painting or music or, the speaker before actually mentioned cooking. You can be very, very creative with cooking. You might not think now that you're coming out of medical school and that, that you have your plans and your world domination ideas, that you may not need that. You may think that, but in actual fact, you do. That part exists in all of us. It manifests in very different ways, but this is the only way to become, to get peace and to be well-rounded. It's literally the only way. You'll find that there are different ways to do it, but you'll feel complete when you do those things. Basically, how do I manage both together? People have sometimes asked me that. Well, I wake up very early in the morning and I do my writing. I have written 1 hour a day for 10 years now. It doesn't take a long time. Once that's done, I can focus on the day ahead, finish the day ahead. After my kids have gone to bed, I will then spend about half an hour revising the writing because, creativity, there's what comes out in the heat of inspiration, and then there's shaping it for someone else to look at it. So that tends to be how I spend my day. I feel I've grown a lot with it. I feel like my own mental health has been helped by it because whichever form of creativity you decide to follow, it will help you express yourself more. And there's a part of yourself that just can't come out in the normal ways, in the usual, here's a subject, verb, and an object, talking about it in that way. Some of them have to come out in splashes of color, some of them have to come out in music, anything, but there are parts of yourself that need expression, and you go with that. And that's really about me. I think that if there are questions, I should probably go with the questions, Artie, if you're able to somehow get the questions to me.
So there's questions in Q&A. You might not be able to see them where you are,
okay.
But there's no questions at the moment
okay.
in the Q&A. But I've got a question for you. I've been quite cheeky in the chair. And you talked about being very disciplined with your writing
yes.
and getting up, and you talked about having children. As somebody who has children myself, I find it really hard to get up in the mornings. How might... I'm not as disciplined as you. I'm also aware that as a group of foundation trainees, people be working shifts, people be working different work patterns, and they might even be looking to work less than full time in the future. What kind of tips would you have for people who do want to pursue either writing as a career or actually it's sort of whether it's performing or something that requires practice?
Yes.
You can't just pick it up and do it, can you?
Yes.
What tips would you have to the trainees?
Okay, so the first thing you need to understand is that when it comes to any creative endeavor at all, there are two main aspects. One aspect is the heat of creation, which is a bit free form, a bit free flowing. That's what people talk about when they say they're inspired and they started doing something. And that kind of can flow out at any time. It can just flow out of you no matter what. If you're more inclined to discipline like I am, you can actually schedule it and make it conform to what you want. But if you're not, it's not a problem. But the fact is, you can snatch time here and there as the day goes by. You can walk around with a notebook, for example, or a sketchbook if you're an artist, and ideas will occur to you as the day goes by. And you may be able to pull it out or you can use your phone and just kind of write notes to yourself or write a little bit and do that. John Grisham actually did that while he was, when he was writing his first novel, because he was working, many people who are working full-time who write novels have to do that. So you squeeze out the time. I have to say that it helps to limit the amount of television you watch. That does help, because if you want to check, you can check how much time you spend on TV. You'll see that actually there is time you can shave off there to deploy in your creativity, whatever it is going to be. So I'd mentioned that there were two parts of creativity. There's the unformed part of it, which is just getting ideas, sketching, doing all that sort of thing. But when you want to make a finished work, Like you want to finish a song or finish a story, you have to shape it. And shaping it is where your experience of other examples of that form of art comes in. You know when something is good. Otherwise, you wouldn't be doing this at all in the first place. So you then try to shape it into that thing. That's the second part of creativity. That part is actually what requires discipline more than the initial inspiration. And that's where you turn it into a thing that other people will see. Now, you may just want to write for yourself. And if that's what you want to do, or you may want to paint for yourself or draw for yourself, then fine, that's okay. Nobody else will see it and you can understand it. That's all right. But if you intend other people to cast eyes or ears or their taste buds on what you have created, then you are going to need to shape it so that other people can understand it. And that means changing arrangement of words, changing the characterization, changing colors, changing it in a way that people can consume it. Otherwise, it doesn't. Otherwise, it's a screaming into the void. It doesn't mean anything. All right. You apply meaning to it in a postdoc kind of way. So everybody has time. It's just that where the time is the question. If you're not an early riser, you don't have to, but it might mean that you are a late sleeper. So you could do it at night if you want to. Although I will say that the morning is a better time for ideas in any field at all. The morning is actually a better time for you because there's a concept called decision fatigue, which I actually subscribe to. Like, because if you've had a busy day and you've been making decisions all day long, you're going to be tired and you're not going to make optimal decisions. In fact, there's research that shows that doctors made the worst decisions between the hours of 2 and 3 o'clock in the afternoon. There's some research that actually says that. And so I actually make sure that I do my ward rounds in the morning, always. I don't do ward rounds in the afternoon when people are tired. So mornings are good, but any time you can find is fine. It doesn't matter. The important thing is that you make that time sacred to yourself and say, okay, this is the time I'm going to concentrate. It works better if you don't have your phone on. It does, because your phone is full of distractions, all right? And it is going to distract you. So try not to have your phone on and try to, even if you do just 15 minutes without your telephone is worth 3 hours with your phone. So just sit down, if you have a break, and thank you, national, not international labor laws, you're all entitled to a break every day. So you can take part of your break while you're eating your sandwich and you can create. And it links into your job or to whatever work you're doing because the solutions that you come up with are creative solutions. It doesn't matter if you're doing fiction or if you're trying to figure out what management plan should I have for this patient. It's all creativity. You have to think of options because I will tell you now, you're just coming out of medical school. They don't tell you everything. The books and the papers don't tell you everything. And you will be confronted with really unique situations when you actually sit in front of a patient, all right? And the books don't tell you everything. So you will have to be creative. And creativity isn't anything other than being competent in a particular domain and knowing how to mix different concepts within that domain, whether that domain be writing or art or biomedical sciences. You still have to know how to use the knowledge you have and combine things in different ways in order to get the effect that you want. So that's what I would say as by means of advice.
Thank you. And there are a few more questions now. Okay. Jessica wants to know, how did you get into medical writing? Did you do a qualification? Are you sort of all self-taught? How do you get started? Apart from the process itself.
Yes, you get started by being interested, because the good thing about writing is that you don't need permission. So you can just sit down, grab anything you have in front of you, like a pen and a piece of paper, and just start writing. I did go to the University of London. I did their creative writing course. It did not help me at all. I'm not disrespecting the course, but it didn't help me. I didn't find it useful at all. I did creative writing courses and I didn't find them very useful. What I found useful was to read a lot and write a lot. Those are the things that I found useful. And writing regularly is literally the only thing that helped me to improve, because the first things you write are going to be bad. You have to accept that. The first things you paint, they're going to be cliched. All your influences are going to come out. But you have to work through that. The metaphor I like for that is when you move into a new house and you turn on the tap and it's rusty. The water is slightly orange. There's an orange tinge when they used to use pipes that had rust in them. You have to run the tap until it came clear. And that's kind of what it is. So you have to run your creativity through so that, one, all the cliches get out, all the influences of other people, they get out, and then the parts that are you will come out. So there are courses, and people are different. Some people, they work for some people, but they don't work for others. It's good if you can have it to have a mentor, but you can't always find a mentor. I spent a lot of time reading writers' biographies because I wanted to know what people did to get to where they got to. But really, the most useful thing was reading and writing and a willingness to just do it.
Thank you. And you've touched on this a little bit already. How do you find inspiration every day for the writing?
Okay, so inspiration is one of those things that people talk about it a lot, and honestly, it will literally only happen to you about 10 to 15% of the time. All right. Do not depend on inspiration because it's not going to come. If it does come, good. You welcome it when it comes, and you can write for hours or paint for hours or, or strum music for hours or whatever. But it's not reliable. Don't rely on it. It's very, very capricious. So what you want to do is say, okay, I want to do this thing. I want to write. I want to paint. Just start doing it. All right. Don't wait for inspiration. You have to see it as a kind of, there's nobody who has achieved anything in the arts or in the creative fields without being disciplined. You just have to say, this is a thing I want to do. And being disciplined doesn't mean you do it the way I do. In other words, you don't have to do it every day. You just have to do it regularly, whatever regularly means to you. And whatever regularly means to your own particular personality. It has to suit you, but you have to do it a lot. The swim, Michael Phelps, all these people who do things that you hear about, they do it regularly. They don't wait until they're in the mood, and they don't wait for inspiration to strike. Inspiration is one of those things that it's good when you can have it, but you don't have it a lot. You just do it because you enjoy it. You just do it because, you sit down, and what you do is you give yourself permission to write rubbish. You say, okay, I'm going to write bad things, all right? Because if you're looking for the perfect thing, you will never start, and you will never be able to show what you've done to anybody else. So you give yourself permission. I am going to write bad ideas and bad prose, and you forgive yourself for it. You're happy, and you forgive yourself for it. It is in the doing of that and in the reshaping of it that you can find maybe. So I write 1,000 words a day. Maybe 250 of those will be usable by the time I finish revising. All right, but in doing that, I keep, you are affirming yourself as a writer the more times you do it. So it doesn't matter whether it's good or not, just do it. And then you can search out for the good parts of that. And then sometimes there won't be any. And sometimes you write 1,000 good words, but don't judge yourself while you're doing it. Just do it. That's what I can say to that.
Thank you. You kind of, a lot of what you talk about, the process and every day, using the time reminds me of, I don't know if you know Joanna Cannon, another psychiatrist who's also an author as well. And I worked with Jo many years ago, and she used to take notes. So for those of you who don't know, Joanna Cannon is also a novelist, award-winning novelist as well, who's also a psychiatrist. And she used to take notebook and write notes in the car park in the hospital at work. And she worked in sort of acute wards and would come back, not necessarily about the patients themselves, but just make notes, and things would fire off, like you say. And those notebooks were filled, not always with, like you say, kind of literary award-winning writing, but just notes, the volume. There's something about... I
literally always have a notebook around me. Literally, it has to be within reach everywhere I go. And, because you never know when an idea is going to strike you. So you just kind of write things. And some of them may be useless. Some of them might not be. I mean, I'm a disciplined person. So every Sunday, the only thing I do is come up with ideas. I task myself with coming up with 20 ideas every Sunday. Now, most of them are bad. They're really bad. You're not even, most of them are horrible. But one or two of them are good enough. So like if I'm commissioned by a magazine to write a short story, I don't have to go struggling to look for ideas, because I've got a book where I've been writing my ideas every Sunday. So I just go in there, find something, and work on that. And that's so I can reliably produce a short story. But it's not because I'm a genius. It's because I have a stockpile of ideas to write. So I'm not going to, for example, if I finish the novel I'm writing right now, which is about a 6th century warrior poet in the Arabian Peninsula, that's what I'm writing right now. It will take me probably the next year and a half to finish it, but I know what I'm writing after that.
Yeah.
So what I'm saying is, I know where I'm going with everything that I'm doing because I just have a habit. Other people don't write like that. Other people wait, and that's fine. But it's always a good idea to have somewhere to write down your ideas when they occur to you. And I did kind of say that inspiration is rare, but it does happen. And so you don't want to be caught without any kind of writing implement when inspiration does strike you, because it will. It's just not reliable.
Keep that notebook handy at all times. Yes. Thank you so much, Dr. Thompson. It's been real. I know it's not been for very long, but it's been a real pleasure to talk to you and kind of hear about all the things, your approach to it, but also kind of the hard work that goes into it as well. And we're really grateful for your time again, knowing that you've got a busy day. So thank you so much for joining us.
Thank you for having me. Bye-bye.
Thank you. Bye-bye. And now it is my great pleasure to introduce Professor Steve Peters. Professor Peters, well, I don't know where to start with all his lists. Like Prudy, whole list of accolades, achievements, areas that he's worked in. Some of these will emerge as we're talking, but in short, whilst he initially trained as a teacher, then went to medical school, trained as a surgeon, then a GP, then it went into psychiatry, was undergraduate tutor in Sheffield Medical School for a number of years before moving to work in Rampton, at the Rampton Special High Secure Hospital, and then from there moving out of the NHS to work with the British Olympic Association, sports psychiatry, British cycling. I think, Steve, you've produced a few Sky documentaries as well, so you moved into TV work, and alongside all of that managed to produce a series of best-selling books, which many of you will have come across, read, used, known as the Chimp Paradox and Chimp Mind Management. And there have been various iterations of that for children, for athletes, but it's a mind management program that's accessible for everyone. He still continues to be passionately interested in research, education, training, working with students, trainees across all disciplines. And I'm really pleased he's been able to spare the time now to talk to you all a little bit about his career. So thinking about, as I said this morning, about remaining in mental health, but doing something different with it as well, doing that over a great period of time. And one of the things that we'll touch on as well is how do you kind of maintain that sustainability to your career. So Steve, welcome. Thank you so much. I know I can see that you're joining us from your car. I know you're really busy.
It's very hot here, but I'm keeping the door closed to keep the noise down, but I'll slightly open it. Yeah, I'm in a car park somewhere off the M25, so I'm on the road at the moment. I've got an appointment, so I'm going to jump from here.
That's
thank you for inviting me, and thanks to everyone who's on the call.
So I'm going to start off with a question. We're going to do this as an interview, aren't we, Steve? Because there's just too much to fit into a kind of 20-minute conversation. So you originally trained as a teacher before going to medical school. You chose surgical training first, then GP, then psychiatry. What was driving all those changes in direction? And does a kind of working broadly in mental health fulfill all those drives now?
Okay, I guess when I was a teenager, I was obviously aware I wanted to help people. So I did look at all the kind of what I thought were people type of careers. So social work, probation service, and teaching, because again, I thought that was something I'm naturally sort of inclined towards, is teaching. A doctor came in sort of very secondary, really. I was much more inclined to be a vet. I'm a great animal lover. But as I'm not very keen on cats, I didn't think that was probably wise to be a vet. So I moved towards medicine. But I didn't quite get there. So when I left school, I did a degree in maths and then became a teacher, did postgraduate training, taught in schools for a number of years. But I was doing a lot of volunteer work in the community, and I'm back driven to, I just want to help people. And I just think it's great. It's such a privilege to do that. And it absolutely energizes me. And so I gain from it. So I think it's a win-win. And so then I decided in my career in teaching, maybe I should get back to medical school and become a doctor, because a lot of people I worked with had medical problems and I couldn't help them. And I was going to GPs for help. And I found at that point, this is a long time ago, over 40 years ago, that the GPs at that point when I was working, didn't seem that inclined to be interested. They wanted to treat what was in front of them. I kept thinking, but you got to see people as a holistic viewpoint from my perspective. So these are just strong opinions I hold. And so I ended up going to medical school, and then it was really just, I wasn't sure what I wanted to do. The reason I landed in psychiatry is at the time at medical school, I didn't think it was taught very inspirationally towards me. And I kept thinking it was an add-on discipline to medicine. I didn't actually see the academic side of it. And I didn't even see the medical aspects. It was only when during GP training, I did a rotation in psychiatry that I had this almost epiphany that said, you know, this is where you're meant to be because it's a subject I hadn't considered. But I realized suddenly how academic it was. I also realized how medical it was, and that hadn't struck me. So I was a bit slow on the uptake. And I couldn't leave the people. I thought they were the most underfunded, undersupported, least understood generally from doctors. I think it's still possibly the case. And so I couldn't leave. So I stayed on and trained in old age psychiatry and general adult. And really, it wasn't planned. I just kept going and ended up as a consultant.
And I guess back to that, do you think, you know, that 30, 40 years later, you're still in mental health broadly, not just psychiatry, but mental health? Is that sort of need, those all that wanting to help people, kind of, do you still get that same buzz from what you're doing now as you were sort of 20, 30 years ago?
Well, absolutely. I mean, obviously, we sort of jumped, you give a potted history. I'm still with Sheffield University, and I know that you reminded me in an email, that was 30 years ago when I taught you as a student, so I'm beginning to feel more than ancient. But I won't retire because absolutely there is a need to help people, and I've still got massive energy, enthusiasm, because for me, it fulfills probably my needs as much as theirs, that I want to see people get the best out of themselves. I want to see people who are not doing well, and I want them to be understood. And my passion for psychiatry was, I felt at the end of the day, like, I'm not knocking all of the disciplines, we're getting people well in order to get quality of life and they can go and enjoy their life. But the mental health was the key. And that was something that dawned on me, that you can get people physically fit, but if their mental health's poor, then really there's no quality of life. But even if somebody's ill, and I work with a lot of people who have chronic medical illnesses, as long as they've got the right mindset and they're in a good place, they can deal with that and still have quality of life. So for me, it became sort of like, this is the king of the sciences. This is the basis for the rest of medicine. I saw it differently. So I'm still there. And now my work has taken me to various places. None of it was planned. Sport was an accident. I keep saying publicly, I'm not a sports fan, but I'm a people fan. And if they take me to sport, then it's something I'll learn. And I guess
you want to tell us a little bit about, I know, Steve, but tell us a little bit about how you got into sports psychiatry, because a lot of people say, if you're not a sports fan, why would you even go that way in the first place? And some, although they'll know you from Chimp Paradox, won't know of your work with British Cycling, with the British Olympic Association, all the other sort of, big names in sport. Tell us a little bit about how you got into it in the first place.
It was by chance. I mean, a lot of my students get back in touch, which is lovely. I said, I've got the title undergraduate dean at Sheffield, and it's a privilege. So I always like to welcome the students, which I've done for the last 30 years. And one of them got in touch out the blue and just said, I've got a cyclist who has an illness, I think, and I'm out of depth. And I remember this student, a really, really good student who was enthusiastic and keen. But I thought, right, if he's stuck, I said, that's fine, I'll come and help. So I went to, I can't name this person, it's obviously confidentiality. So sports people I can name, I'll name. So I went to see this person, and he did really well. And it was the head of cycling who called me and said, what are you doing? And he wasn't a fan of what he called psychology or psychiatry. But he said, what you did turned him round, and he was really successful. And he asked me what I did. And I said, I don't know. I had no idea. All I did is I looked holistically at him. And I'd like to say, just as an interjection at this point, if someone wanted to follow my steps and say, maybe not into sport, but generically in psychiatry, it was invaluable, the training then that I formally got through the system. So I went through the NHS on a rotation scheme. And I feel, looking back, I learned so much from all those disciplines, so much about approaching people, starting to really get streetwise, lots and lots of people. That was the key to success. And then applying the medicine with that people skill. So when I got to sport, it was a case of understanding the environment, which is very alien to me. It was in a velodrome. And from there, I was asked to work with Chris Hoy. So most people have heard of him. He's 6 gold medals. And Chris is fantastic to work with. So I became this sort of teacher as let's look at the neuroscience of your brain. Let's see what it will and won't do. Let's see the rules. And that's where it all started. I thought, I've got to explain to this young man how he operates when he's on a bike. And once I'd done that, they took me to Athens because he insisted, I want Steve at Athens. And a really great guy, Chris, really lovely man. And he won his gold medal. And I do remember everybody exploding and dancing around. And I was pleased for him, but I remember thinking, I better jump about because everyone else is. But I remember thinking at that point, I just want to get back to forensics and Rampton. And so I was persuaded after a year to join the team because I also got approached by British Swimming. I also got approached by about 5 other sports, and it just escalated. And I got a lot of names working with me. It went very public, and that shot me into the limelight. So I wasn't intending. I resisted for 3 years at BBC interviews, and then eventually I was told you're doing it. And I did a really, really terrible TV interview, and I struggled to explain what I was even doing there. But it just took off. And so I realized then I had to do this if I'm going to help people. And I had to explain what model I was using that the students at Sheffield, which is you're part of that, had actually pushed me into explaining, let's get neuroscience in an entertaining but really serious way. And it just took off so big that I was really taken up by this. Hence now, when you come back to the sport, I'm still with a lot of sports personalities, and it's a privilege. I've done 5 Olympics now. But it's not about the sport. It's about me understanding what their environment is. So it wouldn't matter whether it was a teacher, a doctor, a nurse, a bank manager, someone who's unemployed, someone with 4 children who's gone through a messy divorce. It starts to be anything. And I just learned to use my knowledge and skills from what I learned in the hospital system to apply into anywhere that people put me.
So I think that's something really interesting that I think is applicable certainly to the trainees, well, everyone really. So the question was going to be, what advice would you give to trainees? Because when you went into sports psychiatry, it's kind of fledgling sub-speciality. It's really grown over the last 20 years. But right at the beginning, I don't think people even knew what sports psychiatry existed. It was a thing, and now it is a thing. So kind of thinking about trainees who want to go into something which feels niche or a very individualized career path, what advice would you give them? And I think you've already touched on that, Steve. You talked about the importance of a really good general broad-based training and sort of just good people skills. I know it's a bit of a cliche, isn't it? But those things will stand you in good stead anywhere, won't they? Is there anything else you think that's helpful for, you know, if people do want to branch off and pursue something that's of interest to them, but maybe not a sort of set career path?
I don't know what they might do. I mean, obviously, your last speaker was talking about writing books and whatever. Unlike him, I don't sit down for inspiration. I just have to do it, you know. I'm not that gifted. So I just write what I think. But I think if you look, I still feel the strong basis is get yourself a basis in if you want to go into the mental health side of things, wherever you want to take it, media work or whatever. I think you need that basis across a lot of different areas within psychiatry, because I remember I definitely didn't want to do child and adolescents. But I did actually do jobs in that. So I worked in child and adolescent family psychiatry in different jobs. And what I did find is some of the behavioral work that you can do with young children was applicable to adults. You just learn to adapt it and think, okay, we can't work cognitively. They're not going to work that way. So let's work behaviorally. So I ended up with a toolbox. And every time I went somewhere, like say doing drugs and alcohol, you learn, well, let's be realistic about what addicts generally try and present like, and let's look realistically about what kind of people they're going to hang around with and how difficult it is for them to get out of that. So that's a very different proposition to doing, say, old age psychiatry, where you're looking at someone who maybe have folate deficiency and is presented with dementia and is distraught that they think they're dementing, and suddenly it's a folate problem and we can treat this. And I think all of those vast experiences go into the toolbox. So you learn your behavioral work, your cognitive work, your dynamic work, which I think is crucial. You learn the biology, but you also branch out into endocrinology, neurology, and your general medicine. You still have to keep up with everything. And I think for me, an excellent psych keeps abreast of things. And I remember at my review, I was being reviewed by a guy, an appraisal this is, that we have. And he said to me, why have you done this lecture online in gastrointestinal problems that present as difficulties? And I tried to explain, because somewhere along the line, somebody's going to present, so I know what I'm talking about. I can't be an expert, but I can speak the language. So again, if people were saying, I want to branch off into a new area of psyche, or come following what I did with sport, I think first get a good grounding so that you feel I've got a lot of tools in the toolbox. So when I'm presented with some novel situation that maybe nobody's presented with, like me trying to get Chris Hoy to win a gold medal, where you think that's not on the syllabus, I can apply those techniques and work out which one's going to work for him and apply it in a holistic manner, because I've got my people skills again, and the kind of stresses he got within cycling and dealing with the press, for example, and public opinion, the social media. You start learning all of these things. So I hope I'm not just rambling here. I'm just
no. I was going because I think what you're saying about that toolbox, about critical thinking, problem solving. Yeah. I know you and I have talked about this quite a few times before, and I have done with other psychiatrists. One of the things that people see as a weakness about psychiatry is that we don't have blood tests or scans or radiological things that we could determine, yes, this person has schizophrenia, no, they have depression. We don't have those absolutes. But that does mean that we have to much more develop our critical thinking, problem solving, being forensic with our level of detail, and thinking about things broadly and then narrowing it down. All those sort of cognitive kind of skills are much more enhanced because we don't have blood tests and all the other investigations. And I think sometimes some of the other specialities are overly reliant on those investigations. And so that gives you, I think that gives you and other psychiatrists a unique sort of jump off position, that when you are, you know, Tade Thompson earlier talked about kind of novel thinking, about sort of what inspiration is, just sort of putting together things in novel ways, isn't it? And say similarly with you, Steve, you were presented with very, very unique situations, novel situations with which you had to come up with novel ideas. And I think given what you'd experienced before, but also working in mental health, that actually gave you not just the toolbox, but I guess the muscles to use those tools most effectively. That's what I'm here for.
Yeah, and you're right. And also the experience that you gain means you could meet two people in the same job. Let's say that, and it's always a privilege to work with anyone. And I'm going to detour slightly again, say everybody's unique. And that's one of the thrills to me of psychiatry. You never know the person that's coming through the door. So I might get, for example, two teachers who've gone off work with depressive illness, and they both come in saying, can you help? And they both might have the same kind of situation environmentally, the same kind of comments made, or the same kind of beliefs, and yet they present differently. And that's when you've got to be, like you say, a real detective and say, right, is this biologically driven with potentially serotonin, or even one of the more unusual noradrenaline or dopamine receptor difficulties? And what medication have we got them on? What have they tried? You've got to be so thorough. And then you might find it's one of them's in a very poor relationship and one's not in a relationship. And you've got to decide the weighting of that. Is that important in this, to hold this man or woman in a perpetuating depressive illness, which means that even if we treat it, her mind can have the power to keep these receptors from responding. And that's when you think, wow, this is real shades of grey. And the more you see, the better you get. You know, all research shows this, even with any form of therapy. But I think more so in our medical discipline of psychiatry, I think the more people I see, I feel I never stop learning. And you keep thinking, okay, because everyone's unique. So you can't say, oh, I've seen this before. And you never know what's coming through the door. So even though, like you say, I'm not mainstream psychiatry, after 20 years in the NHS, I sort of involuntarily was pushed out to get outside and work in sport and other things, television and whatever. Still, this weekend just gone, I admit this is not the normal weekend, but I had a case of a teenager running away from home and they were distressed and there was drugs involved. I had someone with a domestic violence issue. I had someone with a psychosis who was threatening to kill people. And I got out the blue just through friends who know me, said, please get involved because we're struggling with the services. So it's a privilege to get involved. But again, I need to know what my limitations are as an independent psychiatrist, what I can and can't do. I need to know the system. Now, I'm not knocking the person who's working there, but one of the mental health workers didn't know the Mental Health Act. And I'm explaining, no, there is another section you can use, which goes through the courts and get a warrant. But this is like invaluable that I'm pulling that from 10, 15, 20 years ago from Rampton. And you think, you know, this is why I feel to be good in psychiatry, I honestly got to be really good. And you just got to keep working on this. And to me, it's such a privilege.
Totally. I 100% agree that every day is a learning day. Every single day I learn something new. And that's the thrill of it. I've got some questions from the trainees. So Rebecca asks, how do you suggest utilising the principles you mention in the chimp paradox during foundation years? How would you suggest we apply these when we're under such time pressure, potential emotional distress over these couple of years? I appreciate this is a very broad question, but how can we keep these tools in mind for ourselves and our patients, given the circumstances?
That's brilliant. And it's a great question. And I'm going to try and answer it in 5 minutes. I'll make it simple. When I went into psychiatry, I struggled with my own emotions and lack of confidence at times, and then thinking, well, you're overconfident here and you don't know what you don't know. So I was starting to get into a bit like it's free fall. It was much easier in general medicine, surgery, GP. It was much easier because we had the blood tests. You had a lot to rely on, and psyche you didn't. And I didn't have the experience then, so I had to build it. And I started saying to myself, and this is a plus of being in psyche, apply what you're learning to yourself. And that's not easy. But I started to see the neuroscience, and the reason I brought the chimp modeling, and it's not for everybody, was just to say, when I started teaching it, it became obvious that you really have two battling thinking areas of the brain. And you have this central part which acts to guide, support, take over the computer system. So when you say we're going through all this trials and tribulation, and it is, being a junior doctor, it's not easy. The rewards are massive, and the rewards en route. So look at the rewards en route. I would say the bottom line of what I'm trying to do is say, get yourself into a good place before you leave your room in the morning. That's what my message is. Look at the neuroscience and look at what the systems are in your brain. So that the one system I call the chimp system, because we know chimpanzees operate with exactly the same system, having spoken to a hominid specialist. And we know that if we work in that system, which is not bad, but it tends to be on feelings, it tends to be on reactivity to situation and environment. Whereas if you learn, and it is learning a skill, you turn to the human system, which is the dorsolateral prefrontal areas. If they start lighting up, we gain 3 critical things in the morning. And I do this every day. We get perspective. We work with reality and say it is what it is. And we look at our values. And I tried to say these over years, I've realized that the 3 key things that people work with who are stable. So in the morning, I say to myself, like today, I wasn't sure this will go. All I can say is I'll always do my best. So my values are, have you done your best? If so, that's great. What if it goes wrong and you think, there was criticism, you know, and I think, okay, I'm not going to say that doesn't bother me. It does, but it won't get to me. I own my own happiness. I own my own peace of mind. Nobody else owns that by giving a comment. So what I would be saying is, I'm working with the reality. It is what it is. What do you want to do with it? So either learn from it, which is constructive, or accept it, lick your wounds, and just say, maybe this is not what I should be doing next time. I've learned something. So again, I think for a junior doctor, it's really tough. I think always keep talking. We tell patients this, talk, because we know that when we talk into the air, the neuroscience says that it tends to be our chimp machine talking, but we listen as humans, and we listen and think, okay, I get this. I've got perspective coming in now, you know, and it is a reward system to be a doctor. And sometimes we forget the rewards of when people, which, you know, write to you and say, this, you changed my life.
I think you're absolutely right, Steve. And I think you and I, a bit further in our careers, we do see the rewards, if not all day, every day. We see them. I think it's difficult for some, not all junior doctors at the moment, to see those rewards, but I think it is a really good question. The other thing that I would say to Rebecca is, and it's something that other speakers have touched on, the importance of practice. Whatever model you use, whether you use the CHIMP model or whether you use mindfulness, CBT, whatever approach you use to keeping yourself kind of well in all respects, doing a bit every day or as many days as you can is always going to be the most effective. Nothing's going to happen sort of overnight or even over a few days or weeks, but all the research shows us that if you can keep that habit up, if you can just keep on going, it does make like you say, neurophysiologically and neuroanatomically, it makes a difference. So the scans of people who do, whether they do DBT or CBT, if you scan them before and after, and this is over years, they show a difference in the strength of the dorsolateral pathways, linking through to the amygdala, linking through to the hypothalamus. All those really important pathways in terms of emotional regulation are strengthened by the regular practice of doing whatever it is that you're going to do. So it's the regular practice.
I agree. Can I give them just a practical thing? Because I agree with that. And I think what people tend to do is they create their own problem by saying, right, I will do 15 minutes or half an hour. And that's too much. The evidence for me over these years is we never do that. So I don't do that. I try and get 5 minutes in the morning. That's all. And just say, before you leave the room, 5 minutes. And that's when I look at the bigger picture and say, at the end of today, let's start in a good place and end in a good place. I'm going to be thrown around. There'll be some things I don't expect to come that are not comfortable. But it's what you said is, if I do that, then I've got my mindset at least to start with. And I readjust during the day. And I usually do it about 4 times a day. I'll take a deep breath and think, hang on, just step back from it all. You know, and don't take it too seriously or yourself too seriously. So the things I challenge myself with, and I feel that is the work we can do. And what you said is, the example I give to people is we only move each day by maybe 1 degree, but that 1 degree in 5 years' time is a big difference between where we could have been and where we've got ourselves to. And it's that for me that we have to accept. We keep moving without realizing it. The more we, like you say, every day is best to practice it. Sorry, go on. Next one.
No, absolutely, 100%. And Rebecca's just replied and said that was a really helpful answer. So thank you. It's nice to get the response in the moment as well, isn't it? Validating that. Now, the other question, Steve, is what does sports psychiatry entail compared to kind of, say, general adult psychiatry? And you touched a little bit on that in the sort of the breadth of sports psychiatry, you know, kind of the physicality of it, as well as the sort of the as well as sports psychology. You have to kind of understand how the body works as well, doesn't it? Do you want to talk a little bit about that? I remember hearing you, Steve, talk about kind of the different conditions you've had to work in, and you know, work around the different disciplines, rules. For example, athletes who have to lose or gain a lot of weight to perform in their particular disciplines, and the different circumstances, airports, hotels that you've had to perform in as well.
Yeah, you've got to be flexible and think outside the box, and remember you've got to work with what you're presenting with. But the kind of things that people present with, some of my friends who are sports psychiatrists now, because there's more, I think, people come into it, and there's a new specialist interest group in sports psychiatry that's with the college. And they stick to the strict rule of their sports psychiatrists, as in they treat depressive illness, obsessional illness. So they go down the sort of mental health route, where I've actually, and I'm not saying I'm right, I've mixed and matched. So I've gone into performance issues, group work, dynamic work, as well as mental health. And so that means I might get somebody who, like Chris Hoy, was in a great place mentally. All he wanted to know is there a way I can use my mind to maximize performance? So this was a new challenge to me. And I read around on the research and tried this out and found, yeah, you can. And so I do performance work with a lot of them, except some athletes will come and say I'm in a bad relationships. You're out to now relationships. And that draws again on my work in the NHS that I've experienced with. Or it can be a coach who says, I've got a daughter who's autistic and she's now 13 and I'm struggling. It's affecting my ability to work and travel. So you're in this very like gray area again, where you have to use your skill to solve what's a unique problem. And then drastically, I was in Europe traveling with a team, and I was asked to see one of the coaches. They said he's gone into generalized anxiety, is what they described it as. And when I got to the room, he was in DTs. And you realize suddenly, wow, this guy is actually potentially going to die in front of me. So I'm saying, I remember shouting, saying, get me a beer. And they said, Steve, you can't be drinking now. And I said, I don't drink anyway. But they said, it's not for me. And they didn't get it. But anyway, he came round on a beer. And then you've got to chase up this amazing thing of trying to get him back to his own country. He wasn't British. And negotiate with mental health services, try and learn their mental health act, what they can and can't do, persuade him to go back and get help and follow him up. And so you can see this is so far left field. And probably the hardest was, don't give too much detail, an athlete who was the other side of the world competing, who went into manic disorder and became psychotic, and had to negotiate a section from that country, which was very unique, and then get them flown back to meet them in an airport to bring them under the Mental Health Act here. So, you know, that's severe, but often it's working with a team and dealing with people who are colliding with each other and saying, let's look at communication skills. So you have a lot of what people call them soft skills, and I call them success skills. That's how do we communicate in a way that doesn't antagonize, but is constructive and builds people up. So for me, my sports psychiatry is an umbrella term for dealing with anything that comes to the door involving with people and emotions, behaviors, thinking. So it spans from mental illness right across, but most sports psychiatrists don't do that. They work with mental illness and they run clinics in that, very similar to the health service. So it's up to the psych.
So I've got a question for you, Steve. During your career, you've obviously worked with a number of different very famous celebrities, sports stars, and we're not breaking confidentiality because they've talked about you in their autobiography, so it's very well publicised. I'm thinking Ronnie O'Sullivan and Victoria, cyclist, Pendleton. Yeah, Pendleton, and clearly they talk of you very fondly in their autobiographies, and you clearly had a really, really close relationship with them, almost sort of fatherly relationship, sort of in
grandfatherly now.
Yeah. And I wondered, one of the things as psychiatrists, if we're just sort of straightforward psychiatrists, the importance of boundaries and maintaining boundaries and professional relationships is sort of banged into us right from the beginning. And I've personally wondered how hard, straightforward is it to maintain those boundaries, not just with those two individuals who kind of, there's other issues as well, but when you're traveling to places with these individuals, you're seeing them all day and all night, you're spending a lot of time with them, it's very intense relationship. So even with people who are psychologically more stable, like Chris Hoy, how do you maintain those professional boundaries so that if you do have to section them, it doesn't feel like a breach of that relationship?
Yeah, and it isn't easy. And I think you're absolutely right. When you're traveling, you're part of the team. And, you know, like at the Olympics, I remember Beijing, we didn't have enough accreditations to get a medical doctor to travel with the team. So I had to double up and get insured to cover medically. And every time they won a medal, I had to go to the anti-doping and do the drug testing. So my days, I'm not complaining, they were from sort of like 6 in the morning where you met with them for breakfast for those who compete early. They would then get on a bus and go off to the venue. I would be at the venue until 11 at night. And so you were coming back at 11 and then going for a meal because there wasn't any food at the venue. So you had to live on these nutrition bars, which really are not that nutritious. And you have to be very flexible. So when you're with them all that time, your own needs start coming in, and you just got to remind yourself of your boundaries and say, you're not here to be their friend. You're not here to be their dad. You're here to be a doctor, and you're here to listen and support, but you don't bring your needs to the table. So it's something I'm very careful with, not taking my needs to any of these people. And that's not easy because they want to get to know you. But clearly you get to know them as friends And so I'm still in touch with Chris Hoy, Vicky Pendleton, and obviously we're still working with Ronnie Sullivan, and a whole host of other people. And it's a privilege to do that, because you're seeing a world that I would never have seen from another side, which the public tend not to see. So you're right, but I think that's true of any psychiatrist, that if we're not careful, you know, we can get into difficulties by crossing our boundaries with certain patients who we clearly are attracted to or like, and we've got to remind ourselves that's a no-go instantly and stop before we start. So, but this is true of all doctors. So I've had to help out with doctors who've crossed boundaries and got themselves into difficulties. It's not easy.
It's not at all. And I guess this is a kind of, maybe a bit of a cheeky question, but there is a meaning behind it. Is anyone or any organisation you wouldn't work with again?
I would, yeah. Sorry,
and by that, I sort of broadly, I know you've talked about kind of Football England, the English football team, asking you to go out and sort of do work with them literally the week before the World Cup. You can't do that with a week to go. You can't do anything meaningful, can you, with a week to go to the World Cup? But equally, in terms of boundaries and maintaining those boundaries and thinking about those challenges, how easy, and your own personal desire to want to help. I know what you like, Steve, that, you know, given a problem, you'll always say, right, you're a problem solver. You want to kind of sort it and help people. How do you resist that temptation to jump in and help when you know actually your boundaries or whatever can't be maintained within that situation?
I can maintain my boundaries. I'm not sure that's what I would find difficult. It may be for some people, it's not something that normally troubles me. But like, I'll just go back to the footballers. I want to defend them because everyone always knocks football. And having worked 3 years as a privilege with Liverpool and England, they were great. They were absolutely great guys, very respectful. And I've got a number of them went very public, like Steven Gerrard and Raheem Sterling. I've got to say, Raheem Sterling is probably the most polite and grateful athletes I've ever worked with. So the footballers were great. Would I want to work with them again? I think if I can give the time and what they need matches with what I can offer, then yes. But there are restrictions on what you can and can't do. And my golden rule with any sport is to meet the performance director or specifically the coach. Now, if I get a coach who says, I don't buy into this, I think this is rubbish what you do, and then I don't work with them because you'll cause conflict. My experience has been that it doesn't work. The athlete's then caught in as piggy in the middle, and you get antagonism. So I often just explain that other people might want to work with them, but my experience is I need to work with the coach and the athletes. They're one unit, really. And that's the same with organizations. So I'll work with organizations. I've worked with many household name organizations. As long as the CEO and the exec board say, we'll work with you, then I'll go in and try and do what I can within whatever they want me to do. But if the CEO or the head teacher or the performance director for sports says, not for me, and I'm not happy, then I don't go in because my experience has been it won't happen. They'll sabotage or undermine what I'm doing. So that's just realism. And I feel hard saying to an athlete, I'm sorry, it's not going to work, but somebody else would like to do it. But I don't think it's not the way I can operate.
And finally, I know we've got the last few minutes because you need to go soon to your next appointment, Steve.
Oh.
As I said at the beginning of the interview, I've known you for 30 years. First met you as a medical student at Sheffield Medical School back in, 1996, I think it was.
Okay.
So, yeah, and you are still as enthusiastic, bubbly, bright-eyed, energetic as you were 30 kind of odd years ago. I wish I was. How do you maintain? I think that, again, for the foundation doctors who do feel the weight of the world on their shoulders and how am I going to make it through the next week? How am I going to make it to the end of foundation training? Do I want to stay in NHS? Do I want to stay in medicine? The thought of having that longevity of career feels almost impossible for some people. So how do you maintain this sort of youthful, joyful enthusiasm and love of it all? What is it?
I love the people. I mean, one of the things that I think is really important as a psych is I actually care about the people. So although I'm saying keep your boundaries, I really care. So therefore, when I meet people, the biggest thing they've said to me over the years is, this seems to work because you care. And you can't mimic that, and you can't evoke it. I just think it's within you. If you're a people person, then psyche is a brilliant place, and you'll energize on the people. And again, it's like things that encourage me is, I remember working with a young woman who was suffering with eating disorder. She had anorexia quite badly, and we had our battles, and I was just a senior house officer then and I didn't really know what I was doing, thinking I'm reading up quick, and we didn't really get very far. And I left to go to another job, and it was amazing that 20 years later, she'd seen me on the television. She got in touch and she said, I want you to know that things you said to me started ringing true. So I would encourage people to remember that in general medicine and surgery, it tends to be very instant gratification. You see improvement straight away in the patient with medication or surgery. Psyche, we should be warned, is not like that generally. I have had patients who have epiphanies, but that's not the way it works. We chip away and we take them on a journey. And I try and describe when I'm teaching to say that it's a journey from A to Z in our lives. And we may pick them up on letter D and only take them to E, but we helped. And they may never tell us this, or we may meet them as this girl did and said, you changed my life, but you didn't know it because you left. But everything you said rang true. And she was then saying that she was working as a nurse and she was married with children and she was fine. And that was such a thrill to me. And then I realized I was getting this a lot. People saying, you probably don't remember me. You saw me 10 years ago and something you said really changed me. And it kept coming back and it's great now. So on that journey, a psychiatrist may only take someone from the letter D to the letter G. That doesn't mean we failed. In medicine, we tend to be our surgery A to Z. And I think that's a really important concept, that people who have illness, it may be chronic and long, but we're actually helping them on their journey. So that's one of the things that keeps me going, thinking, you know, I may have just given them one step or one idea rather than a big jump. But I just know that deep down, I've been reassured that you are doing good. And that's why I think for me, there's so much as well. I've got to ramble on now. I'm working on resilience in children, and then I'm working with some of the Cambridge University departments alongside with Sheffield. And we're working on nurses. I'm working on doctors. We're doing, there's a trial going on now to see the model used with junior doctors. I think they're recruiting, or they've recruited 200. And I have to step back because it's my model, so I can't be influencing it. But these kind of things, I work with the police, blue light services. It's just fantastic. There's never 2 days the same. And there's so much to do that I would just love to have some junior psychs who you think, right, you know, but again, it's funding. And also they won't have the experience. So I'll end up saying, well, you need to do 6 months child and adolescent, or you need to do 6 months of psychodynamic, you know. So I'd still be saying, get your experience through the NHS. And maybe that would help them going through what is a really tough time being a junior doctor. It's really tough, but there is a light at the end of the tunnel. And I think you've got to just say, right, just take them one job at a time and speak. Always talk to your friends or get someone to confide in, because that, I think, we know that in psyche. That's a big preventative against depressive illness. So having someone to chat to is, to me, is crucial. So I don't know what people hope to get from this, and I would say what I say to everyone when I'm going is, take what you can from it. Anything you don't agree with, I'm only one person with one opinion and one experience, which is bizarre experience, which continues. But look after yourself is number one. Get yourself in a good place and learn how to do it with whatever model you use, and then leave your room and enjoy life. But you're prepared for it then, rather than going out and thinking, here we go again, and just not having a plan. But anyway, thank you for interviewing me, Artie, and thank you for inviting me. I wish everybody's listening all the best for their future careers.
Thank you so much, Steve. As I said, I'm really grateful. It's always great to talk to you. And yeah, I'll let you go because I know you've got to leave in the next minute.
I've got 10 minutes,
so I don't want to keep on
venue.
talking. Just massive thank you. Look after yourself as always, and hopefully we'll see you soon at the next conference or event. Thanks so much,
Love to
Steve.
do it. Thank you. Bye.
Take care. Bye. So Thanks very much to Steve. Thank you to Anne as well. I can see you still there, Anne. Thank you so much for staying on. So we're going to have go to our break now, and we'll come back from the break. Let me just check our timings. We're going to come back from the break at 3. To Barry, and so I'll let you all go for your break. If you can rejoin at 3 o'clock, I'll see you then. Okay, thank you. Okay. Welcome back, everyone. Hope that's given you enough time to go and have another quick drink, stretch of your legs, whatever you needed to do. And this is the final session of the day. I'd love to welcome Dr. Barry Mullen, who unfortunately, due to connection issues, was supposed to be speaking earlier on, but has very kindly agreed to join us now. So we're really pleased about that. Then after that will be Helen Garr speaking in the pre-arranged slot. So Barry Mullen is a psychiatrist. He's also a staff grade doctor, like Lily, who spoke to you earlier today. He works in the Northwest Deanery and is an executive member of the Eating Disorders faculty. So without further ado, I'm going to hand over to Barry. There might be a little bit of a delay until he gets his slides, but I'm sure you can kind of talk around that in the time we've got.
I will. That's no problem at all. Right. Really nice to meet you all. And there's actually been a bit of a change in the fact that I am a new consultant in eating disorders, and this is week number 3. And I think that that's actually a pretty good time to talk to you guys, just because I'm just at that transition stage of moving from having been a trainee to a consultant, and hence why we've got some like technical glitches, because I've literally moved to a new computer system, etc., and firewalls, etc., coming up. So I suppose my talk is psychiatry, the scenic route, and just because, as it was alluded to, I took a bit of an unusual route in coming through to child and adolescent psychiatry. So I suppose going through a little bit of my route was the fact that I was at school, and I suppose as lots of medical students, I was kind of had other interests as well, but I was still doing pretty well in sciences. And so it was a bit like, what do you want to do? And I thought, do you know what? I'd really like to be an actor. I like kind of the amateur dramatics and the theatre. And so my careers teachers looked and went, what? Don't be so silly. And I know that there are ups and downs and things are starting to change, but they were actually quite good in what they said. And they said, like, okay, let's think about other things that you could do on the side. And I suppose whenever my slides did come up, I've got some quite cheesy slides of things that I probably had in my head that I wanted to be. And that probably looks a little bit like, I think I've got a picture of Will Smith and Jason Statham up there as actors. But often we find that whenever people go into those types of creative careers, that it can be difficult, it can be challenging, and there's, I suppose, finding work can be hard. And so I thought, what could I do part-time? And so therein came dentistry. And so I applied and got in to do dentistry. And I did a year of dentistry at dental school at university in Queen's in Belfast. And then got the chance to leave and actually have a bit of an acting career. So I went and I had that brief flurry. I really enjoyed it for the year. And I suppose after that, Queen's were really good at saying, look, they'd held my place open and says, look, if you want to come back, you can. I'd passed all my exams from the halfway through first year. So I did. I think at that time, I probably realized that I was maybe a bit more like the people who were doing kind of medicine and dentistry than there was whenever I went into the acting world, but I did enjoy it. And so it all goes down to kind of experience. But that was how I ended up doing dentistry. And I finished and then went on and I worked for a year as a dentist. Didn't mind that at all, but the hospital did appeal to me. And so I started thinking about maxillofacial surgery. And I think it was maybe because I never really wanted to do dentistry from the start. But I really like the kind of the hospital environment. And that's where it comes up as to the experience that I had through medical school was probably a lot different to a lot of other people. And that was because as I was going through medical school, I was able to fund my way by working as a Max Fax SHO, and even up in Cumbria, where my other half is from, I was able to get a second on call job. So especially in like my fourth and fifth year of being a medical student, I was able to do that during the day. And then at the weekend, I would go up and be a second on call on the Max Fax list. And it gave me a really good insight. And I think that that's maybe something that we have got difficulties with whenever we go through medical school and our junior doctor kind of our foundation years, foundation year 1 and 2, and the fact that it can be a bit scary, and the fact that for foundation years, you're probably going to do 4 jobs before you apply to go on to whatever specialist kind of register that you're going to be on, be that general medicine, general surgery, psychiatry. And it was in that time as a foundation doctor, I kind of realized that actually now I've finished my medical degree, I can do whatever I want. And do you know what? I'm not also not going to lie. There's a lot of pressure on whenever you're starting to think, especially all my kind of thoughts had been geared up to surgery at that time. I'd been doing my special study modules and different things like that with the Max Fax department. And I'd been working with the team, which was kind of really, really good. But it also gave me a different insight. It gave me an insight as to what life would be like. And I think my priorities changed. At that time of being a Max Fax SHO, I had these things about like kind of pulling people's faces off. And actually you do a bit of that in there, and it's quite cool. But then sometimes you get to the realities of it, and an awful lot of the time it was holding a retractor or I suppose standing for long hours. And with surgery, it probably, we'll go on to the next slide. And I think this is where it comes up. Sorry, you might see where my slides go up and down a bit. That says a bit about the unique experience that I had. So we'll go on to the next one. Is that all right, please? But yeah, with surgery, I suppose I realized that, as it says there, I kind of enjoyed chatting to my patients. And I think a bit of the arty aspect comes through in the fact that I kind of didn't really want to see them as numbers. I went on a really good series of psych lectures as an F1, and that got me thinking. I kind of looked at the consultant who I now know, who was given the lecture, and I kind of went, he doesn't seem that weird. And you know that there's all these stigmas that go through as we're going through medicine and foundation doctors, and actually most of them come quite tongue-in-cheek and we can kind of understand, but I was kind of going, maybe I could do that. So the things that I think that you guys should be doing in foundation year as well is taking that look around. I always say this to medical students as well. You see, even if you're just somewhere for like a short period of time, take a look at the trainees, take a look at the consultants, and try and think about your life and what you'd like in the future. What I did was I went on a taster week, and I'm always quite honest about it all, that I did a taster week in psychiatry whenever I was doing a colorectal job. The colorectal job was a really, really busy job, and so it was actually a nice bit of a break. But it also allowed me to start building up my portfolio. It allowed me to start seeing, okay, is this something that I really do want to take serious, that I want to think about? I started going to conferences. I did some posters for psychiatry, and I kind of started chatting to the trainees and the consultants. And it was funny because I think the consultants started to chat to you in a bit of a different way. And again, I wouldn't try and put anyone off surgery, but there was very different dynamics. And I started to kind of enjoy that more so. I didn't apply for core surgical training at all. I applied straight to psychiatry then. I kind of made my choice, and I'm really happy. I really like my job, and there are a number of reasons why. The next slide, please. That's going into a bit about kind of the surgery. It's not me trying to put people off, but or any other type of area. But as I say, it maybe wasn't as glamorous as I thought. You had to be prepared to move where the best training is, and like I think that psychiatry is getting more and more competitive, which I'm loving, because you want to see good trainees coming through. I think it used to be, And again, I talk about the stigma that was there, that it was a bit like, oh, if you could do anything else, did you do psychiatry? But I'm starting to see now more and more people, I suppose almost a little bit like me, whenever I was going through training, we had someone who'd done radiology, we had someone who'd done obs and gynae, and actually they'd chosen to change. And it was a bit like, there was a different thing that I was getting out of it. Just like I said, in surgery, sometimes the patients came a bit like numbers, and I was getting to talk to my patients. I was getting to spend some time, and it kind of fell in with like a more holistic way of looking after people. I suppose the thing that I kind of joke about is I also like my wife, and it's quite good to see her in the light of day. And I think whenever I was thinking about surgery, there was often times whenever you were maybe coming in the next morning, even whenever you were off, just because there was a big operation on, or there was a lot of competition to get into surgery. I mean, to get into C even, and to help assist. And so often, I think that the work times or the hours were kind of fudged a little bit, and that was by the trainees, not even by the system. And so I wanted to think, okay, well, what can I do that I still get that buzz off and really enjoy, but also I get to have a nice bit of work-life balance. The next slide, please. Oh, and is it back one, I think? Oh, we're going forward. There we go. And so this is my thing about psychiatry, that actually I find it really, really interesting. I also find that actually, if you're willing to put the work in, that there's room for you to be able to go far. Like, I am now an eating disorders consultant in Alderhay, and I'm on the Royal College Eating Disorders Committee. And these are all things that I've started to kind of look, it says it on down there, that there's the opportunity to, you can stay general if you want, but there's the opportunity to super specialize. And I think that's something that kind of interested me, because I still have that drive that I want to be really good. I kind of want to be the best. And I know that that sounds a bit cheesy, but I think that it's good to have a bit of that in it. And I think anyone that's done medicine you've got that bit of a narcissist. Yeah, okay, you want to help people as well, but you also want to be really good. There's the opportunity in psychiatry to be able to get involved in education or research or management. And they're actually things that are kind of pushed and promoted. You see, as a trainee, I felt like really well looked after, and especially as a CAMS trainee, supervision wasn't optional, it was there. There are other areas in medicine where you're having to fight to get your supervision. And I suppose, as I've said, I like the fact that you really can still make a difference in patients' lives, but also I think that I've got a quite nice work-life balance with it, and I think that that's something that we're maybe often afraid to say and to talk to people. I find in medicine in general we're afraid to talk about our work-life balance. Sometimes we're afraid to talk about money as well, and I think that these are all things that we kind of want to normalize, because there is an element of it being something that we really want to do, but I do think that we should all be kind of fairly compensated for it as well. And I think that in talking to those around you, you're able to find out not just good practice whenever it comes to dealing with patients, which is obviously paramount, but also good practice for getting your own life in a good place, because I think that that will make us all better doctors as well. And I suppose that's the doctors that you want to try and work with and be a part of a team through. And I think it's probably got on to the last slide. Usually, I have to say my first slides are like extremely funny, with like dodgy pictures of like convertible Land Rovers and stuff whenever I was talking about why I was going to do dentistry. But now it's trying to think, what do you want to get out of it? And I'm really happy to take questions about, I suppose, the journey that I traveled down, because as I said, whenever I was messaging some of the Max Fax consultants to say that I wasn't going to apply for general surgical training, I remember feeling that as a real stress. I also remember feeling the stress of changing from dentistry to go back and do medicine, because we all start to think about financial constraints, because all of a sudden you've maybe got a mortgage, or you've got a car, payments that you're having to deal with. So they were all things that I had to think about. But actually, do you know what? most of them, it's almost like that plaster. As soon as you rip it off, it feels fine. And so this goes for any specialty whenever you're going through your foundation training. And as I say to the medical students as well, look around you, look at the consultants, look at the type of people that they are, and do you think that you'll fit in, that it will make your life nice as well? So you want to be able to get lots out of your job. Look at on calls, because it's okay thinking about your on calls now whenever you're pretty young, but actually, what is it going to be like whenever your job gets on down the line? Talk to the trainees is probably one of the biggest things, but doing taster weeks and going to conferences, as I say, this shows you. I think I used to do this whenever I was a trainee, probably about 5 years ago. Now I am 40. Think about what you want to be when you're 40, 50, 60. And like, I'm very honest. I'm 40 now, and I think that work is in a good place. I really like my job. All right, I've just started this job, but I have worked with the team as a trainee, because that's the other thing. So I've come back to this team because it was my first ST post, and it was the team that drew me to it, and then allowed me to try and look and see what opportunities are out there. And so I think the Royal College is getting a lot better at looking at this and trying to look at things from a holistic point of view as well, because like I'm currently on the pilot for the eating disorders credential, which is just coming to an end, but there's lots of different opportunities that are out there that can help you with your career and your life. And I think that actually psychiatry can open up lots of doors, because as I said, you can think about management, you can think about research. Like there's so much that we don't know, that actually whenever you're doing research, there's a chance that you might actually be able to change things. And I that can be in a simple way. Like one of the projects that I'm working on at the minute, even though I'm doing eating disorders, is on social prescribing. And that's because I think that it's something that actually could have a really big impact. And it's all about making your job your own, because I think then you'll be better at it. And whenever you're better at it, what's that going to do except for benefit our patients, which is the main thing that we're trying to do. Really happy for any questions. I don't know if I whizzed through that. It was a bit weird with no slides, and that's me. I have to laugh. This was whenever I started as a core trainee. Ireland were in the Euros, and I went to see them, and I think that it was just funny because it just, the reason that I put that on, because at the time, I was really happy because we just managed to get through all that, but I'd had to ask for leave, and there were other things where it was really hard to get on calls changed and different things. But I genuinely find that colleagues and consultants were like really helpful.
Thanks so much. There are questions, but I'm just aware of the time, and Helen's coming on at 3:20. So I wonder whether I could ask you one of the questions live, Barry, if that's okay, and then I could leave you to answer the other questions, which you can access through the Q&A. Would that be all right?
No problem at all.
Brilliant. So the question I was going to ask you live is, as someone who also likes the practical element of surgery, do you miss that after sort of that aspect after pursuing a career in psychiatry? So, and knowing that you're an eating disorder psychiatrist, I used to work as an eating disorder psychiatrist. I can kind of guess the answer, but I'll let you go.
Well, there you go. I think that is probably one of the other draws that's brought me to eating disorders. And again, I probably say things that I shouldn't, but I laugh because sometimes I feel like a proper doctor. And I shouldn't say that, but the reason I laugh is because my mates who are doing like, say, general medicine or other specialties will laugh whenever I say, yes, I have to monitor the bloods and I do blood pressures and pulses now. And they go, they actually don't do blood pressures or anything anymore. I go, but in my clinic, I do. So I still have that practical element that I'm able to get through. And do you know what? People have asked me, do I miss it? I'll be totally honest. No, because I think that I'm managing to fulfill so many other things as I go through. But I do like I suppose, an element of the practical aspect of things.
Thank you so much. And as I said, there's a couple more questions in a chat, which I'd be really grateful if you can answer. If not, don't worry, we can get to them at the end of the session. And just to say thank you and apologies for saying that you're a staff grade when you're actually a consultant. But it's a relatively new change.
Yes, it's only a couple of weeks, and that's my fault. I didn't really send the bio through. But yeah, so
no worries at all. Thank you. So and then I'm going to introduce our final speaker of the day, Helen, who's been waiting really patiently in the background. I'm so pleased that you're here. Dr. Helen Garr is a GP working in Nottingham with a keen interest and extensive experience in mental health and wellbeing. She's passionate about supporting the wellbeing of healthcare professionals and has worked as clinician and clinical lead of the National GP Health Service since its beginning and is known for her down-to-earth, caring and empathic approach. She has a background in psychology and nursing prior to going into medicine from the University of Leicester. And she utilises her psychology interest to underpin her work as a coach and mentor for doctors. Wow. Well, last but certainly not least, Helen, so thank you so much for joining us. Originally, as you will know, the programme was supposed to be Anne followed by you, so kind of apologies for the slight change in order, but I'm so pleased you can join us and I'll let you get started. Thank you.
No problem, thank you. Can you see my screen, my slides? I've just shared my screen.
Yes, yes.
And you're not seeing the presenter view, you're seeing the proper slides.
Proper view.
Awesome, thank you. So I have been waiting, but not patiently. I've been lurking because some of your speakers have been so awesome, and I particularly fangirl Professor Steve Peters, so I came early to listen to him. My bio is a little bit out of date. I'm not sure how you got that old one, so my apologies. I'm now medical director of NHS Practitioner Health, so I've taken over from Dame Claire who some of you might have heard of, who founded our service. And I've taken over from her about 2 years ago now. So I'm here today to talk to you about the service that I run called NHS Practitioner Health. And hopefully some of you have heard of it, but what I hope in the next, I've got 20 minutes, I think we're running a little bit over, is that you'll leave here in 20 minutes time knowing exactly what you can do and where you can get support should you need it. So I want to start by talking to you about a frog. So there is a quite famous urban myth that you may have heard of, that if you put a frog in a pot of boiling water, and if you very gradually start to increase the temperature in that pot of boiling water, the frog is a very clever creature. It will gradually adapt its internal homeostatic mechanisms, and it will adapt to that increasing temperature. And it will, as the water gets hotter and hotter, the frog will carry on adapting and adapting and adapting until it finds itself in a pot of boiling water. Now, you are not a boiling frog, but as I'm telling you this story, this might sound very familiar. So I've heard throughout today lots of people alluding to, and I know, and you know, just how tough things are at the moment working in the NHS. So we can often find ourselves feeling like this frog. Things get chucked at us, patients' expectations. We have to see more and more patients, staffing difficulties, e-portfolios, exams, managing to keep up with all of our CPD, keeping up with our home life, trying to have a work-life balance, trying to keep our house clean, managing sick children, managing sick relatives, having to walk the dog, all of that stuff. And eventually we find ourselves just adapting and adapting and adapting until we find ourselves potentially in that pot of boiling water. It really doesn't help the message that many of us are hearing about resilience. So if you find yourself not being able to cope with all of those things that are being thrown at you, well, then the message is sometimes that you're at fault, not the system. So I want to put this out there right now before I go any further. We are all awesome human beings. We are all awesome doctors, and every single one of us is doing our absolute best. So if you find that you are in that pot of boiling water, I want you to know exactly where you can go to get some love and support. So I wanted to start by thinking about how you're feeling right now. What's the temperature in your pot of boiling water? So have a look at this temperature chart and have a think where you might be sitting at the moment. Now, if I was there in person, I was to ask you all to tell me where you all are, I can absolutely guarantee you, most of you would say you're in the green. but actually, are we really? Because what we do as doctors, we are trained to just keep going and going and going and going. We don't often take the time to pause and take notice and think, actually, how am I doing at the moment? Is there something that needs to change? Now, if you are in the green, absolutely fantastic. I want you to take notice and think about, well, what are you doing that is keeping you in the green? Because you're doing something very, very right. If you are not in the green, if you're on the red or the orange, and if you are, please, please, please know that you are not alone in feeling like that. But if you are in the red or the orange, when did you used to be in the green? What was different? What might you need to do to move you back into the green? And if actually you're sitting there thinking, I'm sitting in the red most days, please, please, please think about coming to get some support. And I'm going to tell you about NHS practitioner health. So as I mentioned before, most of us would probably say we're sitting in the green, even when we're not. We know that doctors just go, 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 go until we crash. So it's really important we learn to not just to check in with ourselves, but also it's really important we learn to check in with each other. When did somebody last ask you, how are you? Now, if that was recently, what a powerful thing when somebody asks you that and really means it. And in fact, I heard that mentioned earlier on today, that in psychiatry, generally, when people ask you that, they often really do care about the answer. Now, sadly, that's not the case for many people. And what happens when somebody asks you how you're feeling? We all know what we do, don't we? We just reply with, well, I'm fine. So the power of asking somebody how they're feeling, the power of being asked, we cannot underestimate. So I really, really do urge you to leave this talk today. And if you just do one thing differently, make an effort to ask your colleagues how they are and really care and listen about the answer. But actually, ask twice, because you will get the inevitable, I'm fine. So ask twice, but how are you feeling? I've noticed you've been a bit quiet. I've noticed you've not been yourself. How are you feeling? Oh, I'm glad you're feeling fine, because actually what I've heard is people are finding things tough at the moment. I'm really pleased you're feeling fine, actually, because I'm finding things a bit tough. We know that doctors who are asked how they're doing, who are given that sort of nudge and somebody reaches in to them, are far more likely to seek support than doctors who feel nobody cares about them. So we're trying to change the landscape from, of course, we want people to reach out and ask for help, but also we want to change the culture so that we as doctors reach in to our colleagues. I tell a story when I was a junior doctor. I was working somewhere and things were tough. And one of my colleagues, who was actually very senior to me, I knew was not right. I knew they were not right, but I didn't check in on them. I didn't ask how they were, and I didn't reach in because they were senior to me. And it felt very much the hierarchy in medicine that it wasn't my place. I remember going home to my husband and saying, actually, if I go to work tomorrow and they're still not right, I don't care about the hierarchy. I'm going to knock on their door and I'm going to see how they are. There was no tomorrow. I'd left it too late. And we know that doctors will come to work when they are feeling suicidal. 1/3 of doctors who come into us at Practitioner Health are experiencing suicidal thoughts, and 1/3 of those have made active suicidal plans. Yet we know if we check in on each other, doctors are far more likely to seek help. So please, please, please check in on yourself and check in on each other. And then it's the message I really want to get across is actually it's okay to ask for help. So the doctors who come to us at Practitioner Health, they haven't come to us because they're weak. They come to us because they are the strongest, bravest doctors I know. It might not feel like that at the time, but to fill in that registration form, to actually put your hand up and say, I need some support, is the hardest and the bravest thing we can ever do as doctors. And we absolutely understand that at Practitioner Health. When you come to us, we completely get how hard it was for you to knock at our door. And we are here to support you, whatever is going on. So it's so hard for us to seek help, isn't it? Things are really tough, yet we're working in this culture where often it feels like we have to be superhuman. We sometimes hear or feel the message that if we're not coping, if we need support, then actually we're not very good doctors. we're not very good people. There's still a lot of shame and stigma around being unwell or needing support as a doctor. So let me tell you very quickly, we don't have an awful lot of time and I could talk all day, but who are we at Practitioner Health? What do we do? And how do you find us? So this is some of our team, but actually we've got a team of almost 300 people across England and also Scotland here to support you. This is Claire Gerarda in the pink cardigan, if you haven't met her before, who founded our service. So who are we, if you don't already know? So the most important thing for me to say is we are here for you no matter what is going on. I often hear people say, oh, I thought practitioner health was just for people with really serious mental illness, when things were really bad. That's not the case. The most common thing we see coming through our doors is anxiety, symptoms of burnout, overwhelm, trauma, low mood, depression. So we're not just here for the severe mental health, which is a common misconception. In fact, we often talk about seeing people just before they get to tipping point. We can support you and help things before things can get really, really bad. We can support when there's a mental health condition relating to a physical health issue, and we also are a treatment service for addiction. So briefly, who can come to us? So what you need to know is any doctor of any grade, of any speciality in England, Scotland, or the Channel Islands, we are open for you to self-refer to us. We're also open for anybody in the NHS, anybody at all in the NHS in England, if due to their role, they have a genuine barrier to seeking treatment and care, usually due to confidentiality. So, for example, we'll often see a lot of staff who work in mental health trusts and IAP services who need support with their mental health, but would be treated in the place in which they work. And of course, that's a barrier to seeking confidential care. If you are a trainee in London, Kent, Surrey or Sussex, we have an additional service for trainees working in that area. And also we are open to all regulated healthcare staff in Scotland. So what can we do? First and foremost, we listen, we care. When you come to us, we will greet you with love, compassion, kindness, and time. We are healthcare professionals who understand completely the challenges of working in the NHS and the difficulties that you will be facing. We have access to talking therapy and various different modalities. Our mainstay is CBT, but we also offer other modalities of therapy. We can write sick notes, we can prescribe, we offer inpatient rehabilitation for addiction. We have lots of different support groups, and I've heard you talk about the power of groups as therapeutic interventions early on today, so you don't need me to tell you about how powerful groups can be. And to reassure you that confidentiality is our cornerstone. We absolutely understand that if you are a healthcare professional, you absolutely need to have confidentiality. We have memorandums of understanding with all the major regulators, including the GMC, that allows us to treat you. And we have a mantra that we, from day one with all of our new staff, it underpins all of that we do at Practitioner Health. We do nothing about you without you, so you can be absolutely assured of confidentiality. We offer a specialised and consistent national offer, so all of the GPs, psychiatrists, mental health nurses that work for us are highly trained experts in this area. And we have our own app to allow people to book their appointments, to pick the doctors that they want to see. Really great, easy access. Most importantly, we offer love, support and compassion. So briefly, very quickly, a bit more about what we do. So case management, in most cases, you will be assigned your own healthcare expert, healthcare professional who walks alongside you and supports you in your treatment journey and will initiate all of your treatment with you. Various therapies that I've talked about, loads of different support groups, constantly reviewing the need for our therapeutic support interventions. And this is our 3 inpatient rehabilitation facilities, one in Scotland, one in Wiltshire, and one in the West Midlands. World-class facilities, and we offer 6-week inpatient treatment for people suffering with addiction. So how can you reach us? We are self-referral, only. So we do not take referrals from other organisations, although often people are signposted to us by the people they work with or occupational health. But as I say, once you come to us, it is entirely confidential. So most people get to us by filling in the form on our website, which you can see here, www.practitionerhealth.nhs.uk. You can, of course, email us or call us if you wish. We're open Monday to Saturday. And we do occasionally have appointments on a Sunday as well. Healthcare professionals who come to us get better, and they get better quickly. Our recovery rates are huge, over 90% for anxiety and depression. The feedback we get is almost universally excellent, phenomenal. People literally say every day, I don't know what I would have done without you. You literally saved my life. I would have left medicine if it wasn't for you. You helped me to enjoy my job again. We do have some fantastic resources on our website. I'm not going to go into them, but we've got some wonderful wellbeing resources, some fantastic expert speaker webinars on there. That's free for everybody to look at. I've had that slide on already, so won't go over that again. And then finally, just so I can hopefully get you off all on time, I was sent this picture by a doctor when I was giving a keynote speech a couple of years ago, actually, and I love this picture. So this picture, this crocus, this is a really blooming resilient crocus, isn't it? Flowers are not meant to grow through concrete. Flowers are meant to grow in really positive environments, rich soil, sunshine, water, nourishing environments. Now, it can feel, working in the NHS, can feel like this flower trying to grow through concrete, trying to survive and thrive in really difficult conditions. So I want you to think about, actually, what are your conditions that you need to thrive? What do you need to be doing every day, however small? And Steve Peters talks about the 1% effect. What's the tiniest things you need to do each day to enable you to survive and thrive? But not only do I want you to think about where you plant yourself outside of work to allow yourself to grow, I want you to think about what you need to do in work. And together, I want us all to start to think about how we change the landscape, how we dig up that concrete and support each other to be able to survive and thrive. So I want to finish by saying to you, I want you to know that even in the darkest times, there's hope and there's growth. And I want every single one of you to know that I see you. We know that you are doing the most phenomenal job and that you are brilliant. And thank you for all that you do. Thank you.
Thank you so much, Helen. And what a wonderful way to finish the day. Positivity, but positivity, a realistic positivity. I think sometimes some of these days, as wonderful as they are, can leave people feeling some kind of conversely deflated. I'll never be like that. What's wrong with me? And I think you're very balanced, hopeful, but balanced talk was just what we needed to pull together all the different elements of the day. So thank you, Helen. And apologies for the mistakes in the bio.
No, that's entirely my fault. My PA has actually been nagging me for ages to update my bio, so it's probably my fault.
But thank you so much. I've got a couple of questions, one very straightforward and one I feel a bit mean, sort of kind of giving it to you. So I guess it could be part of the conversation that we have. So the first one is there a similar service available in Wales?
Answer to that is yes. So they are called Canopy, and you can find their website very easily. There's a link to their website via Practitioner Health, but yes, they're called Canopy, and we work closely with Canopy. They're awesome.
Brilliant. Now, the next one is maybe not so straightforwardly answered, but I think it's a really important question. So I'm going to read it out to you. I don't expect you to have an answer at the tip of your tongue, but it's maybe something for us to talk about, possibly. So I have heard of people who are worried about striking, as they are a certain number of mandatory days in a year to pass the first year of foundation programme. And they're worried about not passing if they are then sick and cannot complete mandatory training. What are your thoughts on having to weigh taking strike days in light of this and worrying about not being able to have sick days when there is a genuine illness? Yeah, and I guess the other bit I'd put into that is also the financial cost of taking strike days. You know, it's not, as the strike days go increasingly on, there's also a financial cost. But I guess what they're talking about is sort of training and sick days, which is your area, Helen. And as I said, I don't think there's an easy answer to this at all.
And we could probably talk about this for hours. So first of all, thank you for raising that question. That's a really brave question that I think lots of people are battling with. And I'm really genuinely sorry that you're having to weigh all these things up, because that's incredibly difficult. The first thing I would say is, and I'm not going to speak because off the top of my head, I don't know exactly, but I'm fairly certain the BMA has put a statement out about this. And if I remember correctly, that strike days cannot be counted towards your out of training time. But I would check that with the BMA, who I'm fairly certain have put something out about that. The second thing is your question about the worrying about taking time off sick because of strikes or illness or whatever, because of the effect it'll have on your training program. Is something we see all of the time at Practitioner Health. I regularly have that conversation with trainees who actually would really need some time off, would really benefit, sometimes even just 2 weeks out of training, just to reset, to pause, to rest, would be hugely beneficial. But it's that additional pressure and stress of worrying about the effect on training. What we tend to see in practice is, number one, I've actually never seen a trainee yet, I don't think that has had their training extended for taking short amounts of time over. If your e-portfolio is up to date, generally what tends to happen in practice, if everything else is okay, this is not a set in stone thing. It's down to the individual ARCP panel. And if everything else is okay, my experience is actually short periods of time over and above the time limit tend to be okay. The second thing I would say to you is, and I have this conversation all the time, that actually, what's the worst thing that could happen here? So actually, if your mental health and your overall well-being, your physical health and your career is going to be saved and is going to be better, and actually you're not going to go into work and make mistakes that might put you in front of the GMC because you're going to work unwell, because you then take time off, what's the worst thing that could happen? And if the worst thing that can happen is your training is extended, actually that feels like the end of the world. But when we weigh it all up, is it really the end of the world? It feels like it, but what's the alternative? Your health, your well-being, patient safety. You go to work, if you are not feeling well, you are far more likely to make a mistake. And if you make a mistake at work because you've gone to work when you're not tip-top, then the effects of that can be catastrophic. So sometimes it's about trying to just weigh up the pros and the cons, but my experience is actually, generally, it's looked really favourably upon when people take time out for their health, because you are taking ownership, you are showing insight, and GMC Good Medical Practice absolutely asks that of you. So it's probably a bit of a fudgy answer there, because I can't guarantee you if you take time off, your training won't be extended. But what I can say is it feels like the end of the world when that's a possibility.